Hello and welcome. Thanks so much for joining Global Liver Institute's Virtual Liver Cancer Tumor Board. I'm Ivy Ahmed, the Liver Cancers Program Director, and I'm delighted to join you today. I'll share some brief background about Global Liver Institute and then introduce you to our program today. Founded by Donna Cryer in response to her own experiences as a liver patient, Global Liver Institute aims to fill the gaps in patient advocacy for those living with or impacted by liver disease and liver cancer. GLI does this through a number of collaborative efforts that convene all stakeholders in the areas of liver diseases, cancer, policy, patient advocacy, and more. As a patient-led and patient-driven organization, GLI holds the patient voice at the center of all we do to improve the lives of those impacted by liver disease and liver cancer. I encourage you to visit our website, globalliver.org, to learn more about the many ways to get involved with GLI. You will find plenty of opportunities, information, and resources. Coming soon, we will be launching Liver Central, a new online resource where clinicians, researchers, and advocates can find up-to-date resources for liver cancer education. Now, about today's program. Our virtual liver cancer tumor board is part of our October is for Livers campaign to elevate the global dialogue about liver cancers. Every person is different, and so too is each diagnosis of liver cancer. Choosing a doctor and a healthcare team to manage your liver cancer is a very important and also personal decision. Today, we are joined by a multidisciplinary group of 6 physicians, each representing a different medical specialty that is involved in the treatment and care of hepatocellular carcinoma, which is the most common type of primary liver cancer. A multidisciplinary team is a group of healthcare professionals from different specialties working together to suggest a treatment and care plan based on a person's unique liver cancer diagnosis, their health, and ultimately their preferences. Today's virtual liver cancer tumor board helps to demystify the complexities with a cancer diagnosis and the treatment options available. Our experts address the ways in which a tumor board will approach, discuss, and ultimately come to a collective decision on a recommended course of treatment for each patient's individual treatment plan. Once the physician discussion is completed, we will have a Q&A session with several of our experts. During the Q&A portion of the program, please type your questions into the chat box. And with that, let's meet our panelists today. We are going to hear from Dr. Lewis Roberts of the Mayo Clinic, who will be addressing hepatology, Dr. Mark Lewis from Intermountain Healthcare, who will be addressing medical oncology and moderating our program, Dr. Jamie Brandt, also from Intermountain Healthcare, who will be discussing supportive oncology's role, and Dr. Myron Schwartz of Mount Sinai Medical Center, who will be addressing transplant surgery. Dr. Arpit Chhabra from the New York Proton Center will discuss radiation oncology, and Dr. Karima Garcia Reyes from Mount Sinai Medical Center will address interventional radiology. For more information about our liver cancer programs, visit the GLI website at globalliver.org. We hope you find this program insightful and encourage you to sign up for our newsletters and connect with us on social media. I'd like to take a moment and thank our October is for Liver sponsors. The gold level, we have AZI and Bristol Myers Squibb. And at the silver level, Trisalis Life Sciences, who is also our founding sponsor of Liver Central. And with that, I'll hand it over to Dr. Mark Lewis.
Hello, my name is Dr. Mark Lewis. I am a medical oncologist, and I am privileged to welcome you to this event, which is Liver Cancer Lessons, Virtual Liver Cancers Tumor Board, part of the Global Liver Institute's October is for Livers, Liver Cancer Education and Awareness campaign. I'd like to welcome you to what is essentially a virtual conference that is quite deliberately going to involve different specialties that participate in the care of patients with liver cancer. One of the things I love about my job, it is inherently multidisciplinary. There is no doctor I know that can take care of every condition. And the complexity of managing liver cancer actually requires a lot of different input. So something that happens, perhaps not to your awareness or behind closed doors, in oncology is we have these conferences that are called tumor boards. Even the name sounds imposing, but their very purpose is to ensure that we are doing the right care for the right patient at the right time. And that requires, again, multidisciplinary knowledge. So often what will happen at a tumor board is it's set up where we can display scans in great detail, and we can look at pathology slides in great detail, and then together we can come to the consensus about what's best to do for a given patient. What I thought would be appropriate today, though, for this audience is not to get too bogged down in those technical details, but rather to allow you to hear the conversations that happen among different disciplines. So with that, I'd like to actually introduce our panelists for this talk, and then we'll start talking about some of the hypothetical scenarios that we'll be discussing in this group. So Dr. Garcia Reyes, I'll start with you. Why don't you introduce yourself to the group?
Hi, everyone. Thanks for having me. So my name is Kirama Garcia Reyes. I am actually at Mount Sinai Hospital in New York, where I am an interventional radiologist focusing on interventional oncology. And I echo the words of Dr. Lewis. I think one of the most fascinating things about my field of interventional oncology is how multidisciplinary it is. I'm sure you'll hear us talk. Dr. Schwartz and I often work together. We do tumor boards on a weekly basis. They also include panelists like the ones that are here today. So thank you for having me, and I look forward to the discussion.
Wonderful, thank you. That's a great segue to Dr. Schwartz himself.
I'm Myron Schwartz. I'm a surgeon at Mount Sinai. I do, at this point, primarily non-transplant surgery, although I've been the director of transplantation in the past. Transplantation is for the younger guys. We run a complete service liver cancer program where everybody sees patients on the same day. I share office with Karima and her colleagues and the medical oncologists so that patients come and are met and plans decided all at one time, which is, I think, the ideal setting. And our situation is big enough that we can afford to do that at Mount Sinai.
Oh, wonderful. Thank you for giving us a little bit institutional insight. And actually, we might talk about how our institutions differ because it's not done exactly the same way everywhere. Dr. Chabra, let's go to you.
Thanks, Dr. Lewis, and just want to thank the organizers for inviting me to this opportunity. I'm Dr. Robert Chabra. I'm a radiation oncologist at the New York Proton Center, which is actually partnered with 3 major academic centers covering Montefiore Health System and actually Mount Sinai Health System. So just a little bit further north than Dr. Garcia Reyes and Dr. Schwartz. But from the standpoint of the New York Proton Center, we have the capabilities of utilizing proton radiation therapy, which is a little bit more specific form of radiation treatments, which I'm sure we'll get into today, and sort of compare and contrast that with my experience being able to deliver both protons and conventional X-rays and how that sort of fits into the multidisciplinary care, which is a necessity really for the management of all tumors, but specifically obviously for liver tumors. So look forward to the discussion today and obviously sharing my knowledge, but also learning a lot from the panelists here. So thank you for the opportunity.
Thank you, Dr. Chabra. From New York, we'll move west to Rochester, Minnesota. And Dr. Roberts, I have to say, I trained with you at the Mayo Clinic. I apologize. I feel like I've let you down with the dress code. When I was at Mayo, I had to wear a suit every day. And here I have a slightly more relaxed attire. But you've been a wonderful mentor to me in my career. It was always a thrill to share patients with you when I was a fellow. And we're really honored to have you on the panel today. So please introduce yourself to the audience.
Great, thanks, Dr. Lewis, and thanks for having me on the panel. So I'm a hepatologist with a focus on patients with liver diseases at the Mayo Clinic in Minnesota, as you mentioned. And I think what I find is that my participation in the tumor boards often begins because the patients have chronic liver disease, which puts them at risk for liver cancer. And it's often that I have them in a program of surveillance where they're getting testing on a regular basis before the diagnosis of liver cancer. And our hope is that in surveillance, we will find the liver cancers at an early enough stage that when we find the cancer, we have treatment options and can come to our colleagues on the panel and say, which of your treatment options you offer is the best one for the individual patient we're seeing. The other aspect is that we find that often when patients are diagnosed with liver cancer, particularly if they've not been under the care of a liver disease doctor, it's helpful for us to, in a sense, do an evaluation, determine what the extent of their liver disease is, and determine what additional treatments they may need to optimize, in a sense, their state and their performance so that they are the very best candidate possible for the treatments that are available.
That's so well said. And again, thank you for participating today. And I will say, so I'm a gastrointestinal medical oncologist. I actually recently stepped back and looked at the entire panel of patients that I manage. And to be honest with you, most of the people in my clinic who have, say, colon cancer or pancreatic cancer, they were completely blindsided by their disease. And so 85% of my patients, by the time they meet me, they didn't get to me via a screening program. They came through some other overt diagnosis. So for the instance of pancreatic cancer, say obstructive jaundice from a tumor that grew in the pancreatic head. I think it's a very different approach to treatment than many of the patients that you're screening so vigilantly, where again, I think forewarned is forearmed. We can certainly talk about that as we sort of stratify the different patients that we will discuss today. I don't know if she'll be able to join us on the panel. I certainly hope so. There's one other colleague who might join us today. Her name is Dr. Jamie Brand. She's a dear partner of mine actually in my clinic, and she is a supportive oncologist. And it's a fascinating discipline in cancer care. I don't know, I see some nodding. I hope many of you get to benefit from similar experts who really take the approach of symptom management as complementary to sort of our direct oncologic care. And I have found it enormously helpful. And if she's able to join us, Dr. Brand has been super in helping my patients deal with the considerable symptom burden of these diseases, which I think is both physical and psychological. So we can certainly talk about that too. I wanted to provide our audience, though, with a little bit more context about, again, this notion of the tumor board. And I found a wonderful explanation in the Journal of Vascular Interventional Radiology that I just might briefly read here. It said that clinical knowledge is tantamount to success in the treatment of hepatocellular cancer, whether in the initial or advanced stages. Much of the procedural management stems from the quantification of a patient's disease. Therefore, it becomes imperative for the radiologists to be familiar with all facets of a multidisciplinary approach. In order to do this, you have to be familiar not just with treatment options, but the appropriate times to utilize them. Knowledge of various staging mechanisms, algorithms, and synergistic chemotherapy regimens will also prove useful in the care of HCC patients. And we might talk about this, but various staging and prognostic factors exist for the classification and management. So we might discuss today, and these might be terms that patients have heard of, the Barcelona criteria, TNM staging, Child-Pugh status, MELD, and transplantation criteria like the Milan criteria. We can also talk, I can talk as a medical oncologist about the term performance status because that comes up quite a bit too. And then I think we need to kind of work together through how we evaluate the appropriate time to talk about surgery, including transplant, when local regional therapies are, when radiation is appropriate, and then when systemic therapy, like a doctor like myself might offer, when that would come into play. And again, sort of our goal today for our audience is that they understand just the basic language, the algorithmic approach, and then they actually see, they visualize this crosstalk that happens between our disciplines. And so they understand what's happening, hopefully, in managing their own cases. So just very briefly, before we get into our scenarios, I just wanted to get a sense from the participants of the panel, how often are these tumor boards convening at your different institutions? And when they do convene, who's there? So I might start with our Mount Sinai group.
So, yeah.
Go ahead.
Aaron, you've done this way longer than, so please hop in. But we actually do weekly tumor boards. We are quite busy. And we usually have so transplant surgeries there, transplant hepatologies there. We have radiation oncologists. We have medical oncologists as well as interventional radiologists.
Yeah, we have about 20 to 25 participants, and we present on the order of 20 to 25 patients each week. We see about 400 new patients a year with hepatocellular carcinoma, and we present all new patients in addition to those patients whose treatment is underway who come to points where decisions need to be made because, based on results of prior treatment.
That is amazing throughput. What a unbelievable clinical volume that you're helping patients with there. And I'll actually pause and just say briefly, I tell my patients too, when they're being presented at tumor board, which typically happens right at the time of diagnosis. And as Dr. Roberts already mentioned, we might kind of see that coming if patients are being screened appropriately. But also what I call forks in the road. And I don't mean that to be sinister, but there come times where I need to know, okay, am I going to continue the treatment that I'm administering, or is it time to switch onto another track? And I think that's an entirely appropriate time for presentation at tumor board if your volume can accommodate it. Dr. Chabra, how about you?
Yeah, I was just going to reiterate that, generally tumor board is done on a weekly basis. As a freestanding facility here at the Proton Center, we're obviously closely involved with the tumor boards that are happening in our partner institutions, again, Mount Sinai included. But at the same time, we're also closely in relationship with institutions that are outside of our three partners. And maybe not so much formally in the tumor boards of those institutions, but I was going to reiterate that there's still crosstalk and continuous crosstalk that happens amongst all these disciplines as we're sort of caring for these patients. And I guess sort of in a sense, that's a informal tumor board, but still sort of a brain trust of knowledge. And so I think it's an extension of sort of what we're doing formally on a weekly basis.
That's so well said. I think it's important also that our patients that are listening know that there are these ad hoc conversations that happen between formal conferences where doctors consult with one another. One term sometimes used in medicine is curbsiding. I've actually seen that happen even more often in the COVID era with the advent of the technologies that we're using today. And I actually think it's only to patients' benefit. And again, to stress to the patients who are listening to this, we make every effort to preserve your confidentiality when we discuss these cases. That's sacrosanct in medical ethics. So that's actually the reason that, with rare exceptions, if any, I haven't seen patients be able to come to their own tumor board because, as Dr. Schwartz mentioned, there's dozens of other people being discussed. However, with the appropriate balance there of discretion, we're able to share the salient facts about your case and then get input from our colleagues. And as you heard also from the Mount Sinai group, I mean, they're discussing a lot of cases each week. So you really have to be pretty high level and synoptic. And then Dr. Roberts, I think I know my time there, but maybe it's changed. Tell me how things work at Mayo.
Yes, so we have a weekly meeting currently, and it's, as I think has been described by colleagues, that fairly similar in how we have a transplant surgery team, usually a hepatobiliary surgeon as well, that focuses primarily on surgery, surgical resection rather than transplant necessarily. And then we have the interventional radiology teams. We have radiation oncology colleagues as well, and then colleagues from medical oncology. And we periodically, not always, will have a pathologist there as well. If there's a case that's really interesting that they've seen something that's remarkable in the pathology for a patient that's relevant to the care of that patient. I think increasingly we will consider also sort of genetics and genomics, and often that's covered by our colleagues in medical oncology, where they will bring up issues related to the genomics of a particular tumor and how that is relevant to the care of the patient as well.
Yeah, and so just to explain that a little bit as a medical oncologist, so I might be dating myself, but when I was in high school, I wrote an essay on the Human Genome Project. And that was an undertaking that took years and years across the globe, billions of dollars invested, so we could figure out, well, what is the normal sequence of our DNA, which is 3 billion pairs of letters long. And when I think back on the complexity and the expense of that undertaking compared to what we can do now, it's really pretty remarkable. So in many institutions, including my own, we can now look at the sequence of typically the tumor, sometimes the patient, but typically the tumor, and get that result in 2 weeks, and often at a cost of only about $1,000, which I know is still a lot of money, but compared to the billions it took to get the genome enumerated in the first place, that's a substantial savings. And it's largely because of the improvement in computer processing. So with Moore's law, our ability to fit transistors into a microchip doubles roughly every 1.5 years. And so that's allowed this unbelievable explosion of informatics and processing. And so it is now actually quite feasible for a medical oncologist like myself, or any of the other experts in this panel, to know what are the genes that are making any given tumor tick. And I will say, across all the tumors I treat, some that's a more fruitful exercise than others, but it's really amazing to have that technology at our fingertips. And it's changing the landscape, especially once we get to the discussion of what systemic therapy looks like. It's really giving us more insight into what each person's cancer, what is making it grow, and what are vulnerabilities there that we might exploit with treatment. So well said, Dr. Roberts. Finally, from my end, I'll say we also have weekly tumor boards here at my institution. Just again, to really kind of zoom out a little bit, we actually have 12 different tumor boards here, depending on what the disease type is. HCC is just one of those. And then we actually have one tumor board that's what we call histology agnostic, which is not driven by where the cancer starts, but is actually driven by exactly these findings that we get from this genomic analysis. So again, Dr. Roberts, that was well said. And then finally, to really drive the point home, what I do in gastrointestinal oncology, there are certain cancers that I think have to be discussed with my colleagues. So for instance, for someone like Dr. Chabra, there are diseases I treat in the pancreas, in the esophagus, and the rectum, where if I'm not collaborating with a radiation oncologist, I am not serving my patient properly. I cannot make all those decisions by myself. And HCC might be the example par excellence, where we need all these different disciplines. So as we think about the course that an HCC patient goes on, Dr. Roberts, I might start with you, and let's maybe just delve into a hypothetical scenario where one of these patients whom you've been following so closely because you know they're at risk for HCC, what happens when you first actually confirm that they now have HCC? What does that part look like, and then what happens from there?
That's a great question. So typically, we've identified an individual as being at risk for development of HCC. And I would say the 4 commonest risk factors are that they have some form of chronic viral hepatitis, so that's chronic viral hepatitis C or viral hepatitis B, or they have a history of non-alcoholic steatohepatitis, we call it, or fatty liver disease, or they have alcoholic liver disease that has resulted in cirrhosis. So those, I think, are the commonest risk factors currently in the United States. And if we identify them as being at risk, we'll enroll them in what we call surveillance. So typically every 6 months, they'll have a screening test. Usually that consists of an ultrasound of the liver, as well as a blood test. And blood tests take many forms, but the commonest is called the alpha-fetoprotein test. So these patients will be having these tests done every 6 months. And the 2 key ways that they come to our attention as potentially having a liver cancer. One is they have an abnormal blood test. So, we see the blood test, the alpha-fetoprotein level is typically less than 5. But if I begin to see it going to 10, then 20, and drifting to 50, I begin to be really suspicious that something's going on. And so then I might, based on the alpha-fetoprotein, get a more detailed scan of the liver if I'm not seeing anything on the ultrasound, which would usually be an MRI or a CT scan. Alternatively, on the ultrasound that's done every 6 months, the ultrasonographer might report that they see a new spot in the liver that was not there before. And that leads us then to go on to do the MRI or CT.
Got it. And if I can just interject there very briefly, one of the things I love about this approach is I find it is very respectful in terms of what we call iatrogenic harm. And what I mean by that, medical oncologists may be more guilty of this than anyone else on the panel, is for years, we weren't really careful about the scans we were ordering on our patients. They were actually incurring, and still do, of course, with CT scans, radiation exposure through the very scan. One way of conceiving of CTs, of course, is, so the C in CT is computed tomography, meaning a computer is taking what essentially are stacks of x-rays in slices and then putting them back together so we can sort of visualize in different planes what the patient's anatomy looks like. But if you're using CT, say, as a screening method, you're then incurring a lot of potentially unnecessary radiation exposure for that given patient. Now, this approach that you were outlining that pairs the ultrasound to the blood test measurement, the alpha-fetoprotein, there's no concern there. And then, in fact, if your confirmatory imaging is an MRI, which is the big magnet, there's no radiation exposure there either. So I just wanted to interject and say that, because I've actually had a lot of my patients express worry now that this has become an issue of their awareness, that they've incurred all this radiation exposure previously, especially if we're now going to get to, as Dr. Chapman might explain, therapeutic radiation exposure. So I just wanted to mention that. Thank you very much.
If I might, just as a counterpoint, mention the fact that we all recognize that ultrasound is really quite inferior technology to diagnose these things, and its choice in this setting, although it is safe, is based on cost effectiveness analyses, recognizing that even in the best of hands, it misses 25% of small tumors. And in the setting of fatty liver disease, which is increasingly becoming common, where it's hard to see the liver in a person that's large and the liver texture is hard, it's difficult. And so that we don't, ultrasound is what's in guidelines, but I think the risk of an undetected cancer may actually outweigh the risk of radiation. We use MRI alternating with ultrasound in many patients on an annual basis. And in a setting where transplantation is the goal, and you have to find them at a small size, it really is important, because it's not uncommon for the first tumor to be found with ultrasound at a size like 5 centimeters, where it's already getting to the borderline range. So
Yes,
it's something that has to be balanced.
Well said, Dr. Schwartz. That was exactly the kind of dialectic I was hoping that we were going to have on this call. So thank you for that. So let's actually maybe drill down there, because you're already hinting at some size thresholds, and so I might actually look to your surgical expertise. So let's say, for instance, that Dr. Roberts, through screening, has surfaced a very suspicious mass, both in terms of its radiographic appearance, and we'll say also an elevated AFP. And you're also right to point out, by the way, and this I think gets forgotten, is that radiologists are people too. The ultrasound technicians that acquire the images are people, and then the radiologists who read them are people. And there's a lot of work being done to add artificial intelligence to the interpretation of imaging to ensure that we are catching things and not missing them. But that's, again, the whole point of Tumor Board, is there's no one person among us who is infallible. And generally speaking, the more eyes you have on a given scan, the more you can perceive. So with that, you were already mentioning that there are some very important sizes that someone in your practice you would consider in terms of what path they're going to go down. So let's talk a little bit more about that. What did you mean by the 5 centimeter threshold?
Well, in deciding how to treat patients, we have to consider both the liver and the tumor. So that we'll focus on the tumor now, but the decision isn't complete without taking into account the status of the liver. These tumors obviously begin small and they grow at some point in the range of getting towards 2 centimeters in diameter, towards an inch. They commonly start to develop invasion microscopically of blood vessels. In patients with cirrhosis, it can happen that multiple tumors start developing. And the 5 centimeter number comes really from an effort to try and identify patients who have a high likelihood of being cured by surgery, specifically by liver transplantation. And it wasn't through a complex statistical analysis of thousands of cases that the numbers came about, but after many years of transplantation for liver tumors with bad results, to the point where when we started doing transplants in the early 1990s, transplantation was considered not a treatment for cancer. If a patient had cancer, they're not for transplant, because tumors that were more advanced were being transplanted. They'd already begun to spread. A surgeon in Milan named Vincenzo Mazzaferro set up a program where he selected patients who had liver tumors, either a single tumor less than 5 centimeters, up to or equal to 5 centimeters, or 2 or 3 tumors, none of which were bigger than 3 centimeters, without any signs of spread outside the liver and without any sign on the scans that the tumor was actually invading into blood vessels. And he decided to offer those patients transplantation and wrote a paper in 1996 was published in the New England Journal of Medicine, the premier journal, even though it was 40-some patients, showing that he got equal results to transplanting people with advanced cirrhosis. And so that he was from Milan. Those are now known as the Milan criteria. And to this day, they provide the basis for the system deciding who gets livers, both in the United States and in many countries around the world. Who gets qualified, not exactly to get on the transplant list, but who the system will give priority to, without which there's really not much way you can get a liver transplant unless you have a living donor, which maybe we'll talk about that at some point.
Yeah, no, and obviously it's such a precious resource, and it's really, I think, important to understand for patients to understand how that's arbitrated. And thank you, by the way. You did a couple of things there. You auto-converted from metric to imperial, which I think is important. Any patient these days who's trying to read their own scans will quickly realize that we love the metric system in medicine. And so you'll often see these tumors, in fact, measured in millimeters and in centimeters. And you also started to introduce some of the European flavor to the terminology, like the Milan criteria. And I think it's important that people understand, where that came from. And to your point, just how, almost dogmatic that's been in determining transplantation. You also said something very interesting, which is, and I should do this as an oncologist, you have to separate the tumor from the host, from the patient, from the milieu. And you mentioned evaluating the liver function in the context of the cancer. So here, I think it would be appropriate to go back to Dr. Roberts as our hepatologist. So Dr. Roberts, a lot of patients, again, will start encountering these terms. We talked about Milan, but also I think a term that comes up pretty quickly is Child-Pugh status. So can you maybe explain to the patients what that means and how you assess that?
That's excellent, thanks. So that's a great question, because what the Child-Pugh status is, or Child-Pugh classification is basically a way to determine how severe the liver disease is of a patient that has typically chronic liver disease or cirrhosis. And the way we do this is by looking at the functions of the liver. And so some of the functions of the liver relate to the fact that, for example, the liver makes one of the major proteins in the blood that helps to maintain our circulation, which is the albumin. The liver also makes many of our clotting proteins that allow us to have effective and efficient clotting if we are to have a cut or an abrasion of our skin. And so in order to measure that, we have a measure that we call the prothrombin time. It's a measure of how well the blood clots. Another major function of the liver it helps to excrete different products or waste products from our body. And one of the big groups of waste products are made when red cells are broken down, and we have a compound called bilirubin that is made. And so bilirubin is excreted by the liver in the bile, which is where bile gets its name. And so those are three key measures that are incorporated into the Child-Pugh classification. The other two measures are things we observe on patients. So one is ascites, or the buildup of fluid in the abdomen. And so we can measure that by looking to see if a person's fluid buildup was easily treated by diuretics or medications that cause increased urine output, or whether they are resistant to these medications. The other thing that we observe on patients is that we know that if the liver does not sufficiently get rid of toxins from the blood, these toxins can accumulate and affect our thinking. They can cause confusion, or when most severe, even a coma. So we assess these blood tests and these clinical measures to develop a measure that allows us to subclassify liver disease by the Child-Pugh class. We call it as class A. Those are the people with the healthiest livers. Child B with intermediate stages of injury to the liver or dysfunction of the liver, and then child C when the liver is functioning relatively poorly.
I think you and I probably have to recuse ourselves for bias here, but I have to say the liver is a pretty remarkable organ. And Dr. Schwartz was saying earlier, how important it is to catch these, tumors at an appropriate time where we can intervene. I think it's appropriate to surmise from what you just said that patients who have that Child-Pugh Class A status, or in many ways have the most treatment options in front of them, and so it's really crucial to find the cancer before it or the underlying liver milieu have tipped into a less compensated state.
Mm-hmm.
Go ahead, please.
From a surgeon standpoint, we think of two aspects of the effects of liver disease. One is the function of the liver, how well it can do these various things that it's supposed to do. And the other is more of a mechanical issue in a way, or let's say a hemodynamic issue. The scar tissue that results from cirrhosis restricts the flow of blood through the liver and results in a higher pressure in the blood vessels that are bringing blood to the liver, causing a variety of different effects and risks like internal bleeding, the low platelets because the spleen gets big. And in deciding whether a person with a liver tumor is potentially someone who could have that tumor safely removed with expectation of a good result, we need to have a patient both with good liver function, Child's Class A, and no signs of this high pressure, which is called portal hypertension. And we have to really consider both of those. And I think most people around the world would agree that if a tumor is technically removable and a person has normal liver function and not significant portal hypertension, then that's the kind of tumor that should be removed. Once you get away from that, that's where transplantation comes in.
Excellent. Oh, that's a wonderful way of explaining that. And again, most patients are familiar with the term hypertension and think about something that we measure here with a cuff on the arm. But what you're talking about is internal blood pressure in that portal system, which I think is so important to think about. So again, for our surgical colleagues, you already mentioned that these organs are a precious, precious resource, and there's a central body that sort of determines the order of transplantation. So can you give us a little bit of insight into that system and how you interface with it?
Well, I can tell you that it's the organization that was empowered by Congress to do this. There's the Organ Procurement and Transplantation Network that put out a contract that was taken by an organization called the United Network for Organ Sharing, UNOS, which is based in Virginia, and which runs a national system that all transplantation in the United States is obligated to be part of. The country, there have been a lot of changes over the past few years in how the system works, but there's a national registry. All patients, when they're put on a transplant waiting list, are registered with UNOS. All donors that are potentially usable for a donation come to the attention of the local and regional networks for organ procurement. And there's no region in the country that's not within an organ procurement region. And those donors go into the national computer network. And based on the distance from where the recipient is, the blood type of the recipient, and other characteristics that may have been specified, as well as how sick the patients are. And this is something we haven't yet discussed. With Dr. Roberts maybe can talk about the MELD system, which actually was developed at his institution. But the patients are prioritized and a match is made. It's like a big matchmaking system that is based on the distance from the organ, the characteristics of the patient, and primarily how sick the patients are. There's a special twist when it comes to cancer, and we'll talk about that.
So, Dr. Roberts, we've already been using a lot of terms. We'll now add to the alphabet soup MELD. So, do you want to explain MELD to our audience?
Yeah, so MELD gives us another viewpoint on the liver disease that a patient has. And so I think viewers hopefully are getting the idea that liver disease is not monolithic. It's a little bit like the elephant, and sometimes when we approach it, it's a little bit like blind men and the elephant. And so we look at different snapshots of it. And the MELD was one approach to trying to understand the severity of liver disease that was developed by colleagues here at Mayo Clinic. It stands for Model for End-Stage Liver Disease. And the original version of the MELD used three variables. One of them was the bilirubin, which we talked about, bile. The other one was the international normalized ratio of the prothrombin time. We talked about the blood clotting aspects of the work of the liver. And then the third one was a little bit more surprising, perhaps, was the serum creatinine. And one of the other dimensions of liver disease is that we learned that the liver and the kidneys function very much in synergy. And in order for the kidneys to function effectively, the liver has to be functioning well, and vice versa. And so what we see in the case of the MELD is that having an elevation of kidney or worsening of kidney function, which leads to an elevation of a creatinine, which is a blood test, is again a marker for poor liver function. And so these are used in a model to create a score that then was used to predict the outcome of patients with liver disease. Now, subsequently, it was an addition to the standard MELD of the sodium, which is again another marker in the blood of poor liver function. And again, it relates to the interaction between the liver and the kidneys and the ability of the kidneys to excrete sodium. And so what we call the MELD sodium is, I think, currently used more typically within the transplant arena.
So I think our viewers are already getting a sense of all the different variables and all the different stakeholders that have to come together to make the right decision here. So back to our Mount Sinai group, and Dr. Chabra, I promise we'll get to you as well. You mentioned already, Dr. Schwartz, the sort of algorithm that you have in terms of considering the operation, whether the cancer is going to be removed or whether the patient is going to receive a transplant. Can you be just a little bit more granular in how you make that decision?
Yeah, for us, first of all, not everybody needs a transplant or a surgery in order to be cured. There's an increasing role for non-surgical treatment, and Dr. Garcia Reyes can talk more about that, but more and more, we're treating patients with small tumors, certainly 2 centimeters or less, and as the techniques are improving, it may be heading up towards 3 centimeters, primarily with non-surgical treatment, rather than doing either a resection, which is removing part of the liver, or a transplant. For us at Mount Sinai, we follow more or less what I said before. If there's a tumor that technically can be removed in a patient with normal liver function and no portal hypertension, then we will generally perform a resection, remove the part of the liver where the tumor is. Now, depending on where in the liver the tumor is, that can be a very simple thing that can be accomplished with minimally invasive surgery, or it can be a pretty difficult thing to do if it's a tumor in the center of the liver that may require a bigger procedure with other things done to prepare in order to make it safe. But transplantation has the limitation, practically speaking, that the tumor has to be within those size and number limits that we mentioned,
yes,
in order for a person to get priority on the waiting list. There's so many things to talk about. I mean, what that priority means now is different from what it meant a few years ago, and it's become tougher for patients with tumors to get livers from the transplant waiting list. But if it's a person who has a bigger tumor than 5 centimeters or more than 3 tumors, then transplant is, for the time being, off the table, and we either have to see if we can remove it by a resection or else hand it over to Dr. Garcia Reyes to see if we can treat it in a way that brings it down to where it can render the patient eligible for a transplant.
Okay, so that's a perfect segue to Dr. Garcia. So Dr. Schwartz, just something very intellectually generous there as you acknowledge the role of these other specialties who can intervene on the liver. You know, I was a medical student in my surgery rotation. I was taught the only way to heal is with cold steel, but I think you just told us that there are other options. So Dr. Garcia, tell us about some of the tools that you have. And I may ask you actually to clarify some terms that, again, that patients might hear. Sometimes we hear about downstaging. And I'd just be curious to kind of get your take, how you'd explain that and how you do it.
Sure. So I'll start, Dr. Lewis. I'll start talking a little bit. It's not uncommon when I see patients from Dr. Schwartz or their colleagues or that are sent to me, they really don't understand what an interventional radiologist is. So basically, I should have done this during my introduction, but I'm an imaging expert and I'm a proceduralist. So basically, I use imaging to guide procedures. Live X-ray, we can do it also with CT, ultrasound, and so basically imaging, we study the procedural part, and then we can get to places in the body that a lot of people can't through vessels or just using percutaneously, just using techniques. So back to our role with hepatocellular carcinoma is pretty enormous, and it's like Dr. Schwartz was saying, it's evolving. And I'll get to the bridging and downstaging in a second, but I'll start by talking, Dr. Schwartz was talking about sometimes even in patients who have small tumors, we don't even have to, and tumors might be in a location not amenable to surgery, but now we actually can perform procedures for curative intent. So we have several options for that just in general terms. We can do thermal ablation. By that, I mean, we can use imaging to guide probes percutaneously, so through the skin into the tumor, and then we can either, by thermal, I mean, we can freeze it, we can microwave it, or heat it, so we can use cold heat in order to try to kill this tumor. So that's one big general category that we can use for smaller tumors. The two other treatment modalities we generally have, one of them is called TACE, or transarterial chemoembolization. Which basically what we do is we try. One good thing about the liver, as we have all talked about, and we're here because of it, is a fascinating organ. Has dual blood supply, so oxygenated blood comes from different parts. And the advantage we learned from hepatocellular carcinoma is that whereas the normal liver gets most of the blood flow from the portal vein, these tumors actually get a lot of the blood flow from the hepatic artery. So we can take that to our advantage, and we can get into those arteries, get to the tumors, and provide selective treatment just to that area, with the goal that the systemic effects or the side effects you get from these treatments is lessened. So we can do that with chemotherapy, some chemotherapeutic agents, and then we can also do that with radiation, which I know Dr. Chabra also will talk about as well. Also, and then there's another category, so transarterial embolization, which is without any type of chemo. It's just beads to stop the blood flow to tumors, but we use that a little less here for hepatocellular carcinoma. So we're involved in that early curative stage. How we decide which treatment to do depends on, again, how healthy the liver is, the size of the tumors. So we have this discussion with our colleagues, and we come to those decisions. Another big role for us that is one of the fascinating things, and we see a lot here, is these patients that are transplant candidates. Okay, so that before I get to the ones that are not yet, as Dr. Schwartz was alluding to, the waitlist times for transplantation can be very long. And whereas a patient might be a candidate now, if we really just we can do surveillance, follow the tumor, but there's that tumor will actually grow and they might get outside the criteria. So our role, even we can actually do chemoradiation, we can do radioembolization, which is our preferred, what we do mostly here, and we've studied it a lot in this institution, to try to either cure them, right, while they're waiting for their transplant, or try to keep these tumors, how we would say, during that size or at bay. Downstaging, what that means is, as Dr. Schwartz said, sometimes patients are outside that Milan criteria. So our role is, again, we're always hoping for the cure, but our role, at least in these tumors, is to at least try to bring patients within that criteria. so that then they can be put on the transplant list. So we have a lot of roles in the treatment of the disease, and that's why it's so great to be at a center like this, working with colleagues such as all of you, because I think things are evolving. Our technologies and what we can provide as interventional radiologists, the data, we have more data, which I mean we're doing more studies and studying it more. We're getting better treatments that are a little bit less toxic for patients. So I think it's a pretty exciting field to be in.
I just want to clarify one thing that has always been an issue for me. In cancer, there's no such thing as downstaging. A patient comes with a cancer that's reached a certain point in its development, and it's given a stage, and hopefully you can improve the patient, but that's the patient's stage. And in transplantation, we have these limits, the 5 centimeter limit, let's say, because statistically, patients with tumors beyond 5 centimeters have a higher likelihood of having begun to spread outside the liver. We're going to do a liver transplant. We don't care if the entire liver is 100% replaced by cancer, because we're going to take it out, give it to the pathologist, and put in a fresh new liver. The only question is what has escaped from the liver. And these criteria, the Milan criteria, are a surrogate, a simple way of judging the likelihood that the tumor has begun to spread. No doubt there are people with tumors beyond the Milan criteria who could have a transplant and be cured. And we know there are lots of patients with tumors within the Milan criteria where it comes back afterwards. But statistically, you need something to work with. And so that's the Milan criteria. And by downstaging, if you have a patient with a tumor beyond the Milan criteria and you treat it, Karima gives it whatever, radioembolization, and now it's 4 centimeters instead of 6 centimeters, that doesn't change the fact that the tumor was 6 centimeters and may have begun to spread. So that the whole basis of downstaging is to sort of freeze things in time and then take enough time to watch what happens to the person to see that nothing starts sprouting out in the lungs and in other parts of the body. So that downstaging is really just a way of giving us a chance to observe the natural history of the tumor, because we don't know if that 6 centimeter tumor had begun to spread or not. And this gives us a chance to find out.
So well said, Dr. Schwartz. And it's such a pervasive term in our literature that I'm glad that you dissected it a little bit there.
Dr. Lewis, I was just going to piggyback on that point to add more verbiage, I guess, to our encyclopedia that we're building here. But something called dropout rate, which I think Dr. Schwartz is kind of alluding to some degree, which is, transplants are not easy to come by. Certainly, there's a lot of criteria that patients, but the tumor have to fit, the liver health has to fit, and then obviously you have to have availability of fresh transplants. And so, as Dr. Garcia Reyes was also alluding to, what interventional radiologists, what radiation oncologists like myself are trying to do is to slow the progression of these tumors, hopefully halt the progression of these tumors for patients who are transplant candidates, to try to reduce their risk of dropping out off the list because of either growth of the tumor or change in the health of their liver, or other various criteria that would preclude them from getting a transplant at some point. And as Dr. Garcia Reyes mentioned, within those therapeutic options that are present for bridging or for halting the tumor, they're essentially, I think, categorized as something called local regional therapies, which many patients may come across. And there really are a host of things already on the table, some of which Dr. Garcia Reyes has alluded to, others that I'll sort of add on to, and even more growing options. I think it's just a very much an evolving field. But what I would say is, from that standpoint, to kind of add to the list of potential therapeutic options that are available for bridge or for control of the tumors, includes sort of radiation treatments as well. One of which Dr. Schwartz and Dr. Garcia Reyes sort of alluded to, which is radioembolization. So radiation can sort of come in two flavors, which is external radiation or internal radiation. Radioembolization is internal radiation, specifically of radioactive beads, that are sort of taking advantage of the differentiating vasculature of the liver to deliver radioactive beads in the vicinity of where the tumors are located, in essence trying to cause cell death, cancer control in that localized space. And on the contrary, you have external radiation treatments, of which there are two major types, which I'll sort of talk through. But as the name alludes to, you're delivering the radiation through the skin externally, again, precisely targeting the areas of interest within the liver that you're obviously trying to deliver radiation to. And not to add more complexity, but within external radiation, there are conventional X-rays, and then there is proton radiation. And really, I think the essence of the difference, not to get too much into the weeds, is conventional X-rays I sort of describe to patients as probably a bad analogy, but it's kind of like a flashlight in that, if you're trying to treat a tumor, let's say that's here, and you're coming through the skin to treat this area, X-rays, just based on their physical property, will continue traveling through and through. Certainly with less energy because they've delivered the majority of it to the tumor itself, but unfortunately it will continue thereafter. Whereas on the contrary, proton radiation, trying to treat that same target, again, externally comes through the skin, treats the area of interest, and then stops within a few millimeters to a centimeter thereafter. Why is that important? That's important. Going back to a point that was brought up earlier about Dr. Schwartz brought up, which is you really have to appreciate not only the tumor, the size of the tumor, the number of tumors, the location of the tumors, but the liver health itself. And so one of the things that's imperative is protecting the liver health in patients who are already somewhat tenuous in terms of what their underlying liver health would look like. And so if you can imagine, in certain scenarios, X-rays work very, very effectively in controlling these tumors, especially when they're small or they're peripheral, if external radiation is being considered. On the contrary, though, when the size of the tumor starts to get large relative to the size of the normal liver, that's when it's imperative to further protect the underlying liver that's not involved. And that's where sort of the balance between considering conventional X-rays or something that has no exit dose and less dose, such as protons, you sort of start to have that discussion. And so, again, not to get too much into the complexities, but essentially from the standpoint of adding onto local regional therapies such as TACE and RFA, which Dr. Garcia has mentioned, there's also radioembolization internally and then external radiation to sort of add to only probably four of the many other pieces that we haven't touched upon, but local regional therapies that are important, I guess.
That was all really well said, Dr. Chapman. Thank you so much for taking the time to explain the different forms of radiation. I have to tell you, I recently sent someone for external beam radiation, and he came back to me and he expected to see a giant red laser, like in Goldfinger, I guess. And he found it quite anticlimactic when he was underneath the linear accelerator and he felt like nothing happened, but I assured him the energy had been delivered. And actually, I'm really glad that you did bring up protons, because I think patients are very savvy and are increasingly looking for, I don't know if precise is the correct term, but more precise delivery of these energies. And you mentioned the physics of the Bragg peak and trying to minimize collateral. I think that's so crucial. So can I ask, Dr. Chopra, because I want to give you time to talk about your approach, when would you typically encounter the patient in the series here, kind of meeting different consultants? I'm guessing often after they've been evaluated by a surgeon or possibly by an interventional radiologist. Is that right?
Yeah, I think it's a really great question. And I think it sort of boils down to maybe a little bit of oversimplification, but from the standpoint of thinking through whether a patient is a surgical candidate or a not surgical candidate, and in that setting, assuming that they're not metastatic. So we're assuming that their disease is still predominantly localized to the liver itself. But in those patients that Dr. Schwartz is sort of considering and his colleagues are considering for surgery, I would suspect that many instances where we would be thinking about external radiation or even internal radiation would be alongside sort of Dr. Garcia Reyes about local regional therapies and whether we need to bridge or halt the tumor to try to help the surgeons eventually do what they need to do. So that would be one area in terms of having a collaborative sort of multidisciplinary discussion about what is the best approach. And I think Dr. Garcia Reyes kind of tapped on it a little bit, which is determining the size of the tumor, how close it is to blood vessels, for instance. Is it 2 centimeters? Is it 3 centimeters? Is it near a blood vessel? Is it peripheral? And that sort of dictates what may be the best approach. And one thing I will highlight is that there are sometimes overlapping approaches where a few things could work. And it's not necessarily a black or white, where we're sort of on a spectrum. And similarly, there may be a combination of things that might work. And so that's really where the discussion is happening at Tumor Board about, at least for a surgical standpoint, if we need to bridge or come in along with our other colleagues. I'd say the majority, however, of individuals for whom external radiation treatments and internal radiation treatments are predominantly used, at least in my clinic specifically, are patients who are felt to be unresectable for whatever multifactorial reason they may be. And in that situation, it's generally after a hepatologist, a surgeon, potentially even an interventional radiologist has seen the patient and deemed that they are felt to be unresectable, but that we can still offer them an approach of long-term control. And that's where sort of the decision point about whether internal radiation or external radiation is more applicable, and then amongst external radiation, which we feel is the safest for that patient.
That's perfect. I think that conveying intent to patients about why they're undertaking treatment is so crucial. I mean, I think it's actually integral to respecting their autonomy. But I think what we've already touched on multiple times here is it's not always entirely clear when we begin treating someone what the outcome is going to be. And I'm not going to use the term downstaging because I know Dr. Schwartz doesn't like it. But the point is that you don't always know what's going to happen. And actually, that brings me to my next question, perhaps for Dr. Garcia-Reyes and Dr. Chabra. When you intervene, say whether radiation or an interventional radiology approach, what is the latency? What is the time period that you allow to elapse before you determine how well it has worked?
So I can take a stab at that. So depends on the type of modality, but usually, if we're doing some type of ablation RFA, we immediately after the procedure actually get a contrast enhanced scan and have a pretty good idea of the result. And then we see a patient 4 weeks afterwards. When we're doing the types of local regional therapy where we go into arterial, we actually, so we see patients 4 weeks, and then at 3 months and 6 months, we evaluate, and that's kind of the timeline. And I think Dr. Schwartz touched on when we were talking about the not using downstaging. I think he touched on something really important, is that we can see a lot of tumor biology. We can see a lot of how the tumor is going to progress, and in those scans, like, is the tumor responding to this therapy or not? So that's why we like to see the patients pretty early on with imaging as well. Of course, we evaluate them for side effects or any issues that are from the treatment itself, but we also like to see what's happening to the tumor.
Yeah, I would just echo that. I think generally, at least at a month after, is our institutional approach, in part just to kind of get a sense of, one, are they having any acute toxicities? Just how are they doing? These patients are we have to be very careful with a lot of our liver patients, in part because of what we've talked about, and Dr. Robert just mentioned, that a lot of them have underlying cirrhosis, very tenuous, fragile livers, and we have to be very careful to ensure that anything that we do while we're really trying to achieve tumor control or tumor halt doesn't ultimately cause undue side effects. And so I think one is their approach to make sure that they are not facing side effects, but then similarly adding on imaging, as Dr. Garcia-Reyes mentioned, usually at about every 3 months to ensure we are not seeing any radiographic signs of progression.
Actually, it's so crucial that the time that is elapsing there is not idle time, it's not lost time, but it's also time that is allowing the disease biology to declare itself. Because I completely agree with what Dr. Schwartz said earlier, is that if you go through this massive undertaking, whether it's a surgery or certainly a transplant, and then you see the cancer blossom elsewhere in the body, it is such a pit of your stomach feeling. It just feels like such a disappointment and a loss. And I say that actually somewhat personally, and I'll explain what I mean. So in 2017, I actually had a cancer removed from the head of my pancreas. It's called the Whipple operation, which people like Dr. Schwartz can probably pull off. I know I can. Regardless, a lot of my patients who go through that surgery for the conventional form of pancreas cancer will then develop metastasis. And it can happen within months of this huge life-changing operation. When I see that, it just feels to me like such a retrospective catastrophe, because the operation's huge, it erodes months of quality of life, and then you see the metastases, and it feels like it was such a pyrrhic thing to do. And so I completely agree with the emphasis here. Not that we're excluding patients from life-preserving approaches, but that we're being extremely thoughtful about what we do, especially when a precious and shared resource of the community like organ donation is being considered. Very briefly, I do want to get back to Dr. Schwartz on the transplant list in just a second, but I also want to welcome a dear colleague of mine, Dr. Jamie Brandt, to the panel. Dr. Brandt is a supportive oncologist. Jamie, just to bring him up to speed, what we've been doing is we've talked transplant eligible HCC patients, patients who might become transplant eligible. And then you and I in a minute actually can get into what this looks like in the more advanced stages. And if it's not too difficult, I think we might actually talk about some of the symptom challenges that these patients face. But welcome to the panel. We're thrilled to have you. I think you might be on mute. That's okay. All right. Dr. Schwartz, you mentioned earlier the changing calculus and even changing timeframes around transplant. You gave us a wonderful historical perspective going back even to the 1990s. Can you explain a little bit more what you meant about the modern landscape? And then what is a typical wait time to get a donor or a patient?
So the MELD system was specifically designed to predict the likelihood of a patient dying in the short term from their liver disease. And it was really, I mean, Lewis can correct me, but I think it was integrally tied to the idea of who should get transplant. This was a big part of the basis of the development of it. And so that these days, if there are a bunch of patients on the waiting list, all other things being equal, the tumor will go to the patient on the waiting list with the highest MELD score. And if there's more than one patient who has that score, then it'll go to the patient who's been at or above that score for the longest period of time. Now, that works fine for people who are very sick, and that's why they need a transplant, because their liver's not working. But cancer patients are different. Their livers are basically working okay, but they have cancer, and if they don't get a transplant relatively soon, the cancer is going to spread and they'll die of their cancer. And so that this was recognized, and early on in the transplant world, it was decided that people with cancer would get an arbitrary amount of priority on the waiting list, and that periodically, if they hadn't gotten a liver, their priority would increase every 3 months until they would finally get a liver. And when the MELD system was first introduced, the level of priority that was given to the tumor patients was so high that pretty much all of the patients with tumors got transplanted within 3 months. And it was felt that the system had been miscalibrated and that transplant patients were getting too much priority. So there have been, I think, maybe 4 now iterations of the system which have progressively lowered the priority of transplant candidates with cancer relative to the patients who have liver disease at the end stage. And part of the reason is that for transplant patients, increasingly, there are alternatives to transplantation, whereas a person with a sick liver and a MELD score that's very high is predictably going to die within the next 3 to 6 months. A person with a cancer may be treatable by Karima and then live for a couple years. Maybe they'll eventually die of cancer, but it's not the same. So the current system is like this. We look at where the patient is, and this is hospital by hospital. And we look at all the patients who've received transplants within the geographical region around the hospital, let's say within a 100-mile circle around the hospital. Let's say at Mount Sinai, there were 100 patients transplanted over the past 6 months, because this is recalculated every 6 months. And the highest MELD score was 40 and the lowest was 15. So that we take those 100 patients and line them up from the highest to the lowest MELD score. And we pick the one in the middle. It's called the median. The median MELD score, the score at which that 50th patient out of 100 was transplanted. Well, we take that score, take away 3 points from it. And that's the score that patients with tumors now get on the waiting list. So that they get a score for the region where they are of the median MELD, which patients have been transplanted over the past 6 months, minus 3 points, which means that patients get transplanted below the median. I mean, that 50% or above 50 below. A relatively low priority, which does vary to some extent based on how many livers are available in a region. But in our region, for example, the waiting time for a transplant is typically over a year, because different blood types are more or less common and may be used the O blood type, for example, a O donor liver can be used for anybody, and occasionally they are, even though we try and avoid it. So patients who need O livers, because an O person can't receive anything but an O liver, have a longer waiting time. It can be up to 2 years for a person with O blood type in our region to get a liver on the waiting list.
Wow.
So that's the way it works. The priority has been progressively lowered over time.
And Dr. Schwartz, I think I know the answer to this, but I think there's a contrast here actually in time frame where, yes, these patients might have to wait years, but then once you actually know that a liver is available for them, how much time do you have to operate?
Well, we tell patients they should be able to be at the hospital within 4 hours of getting a call. We like to get the livers in quickly. We are now starting to use perfusion equipment where we take the liver out, put it on a pump with blood circulating through it. Maybe you can keep it for a day or more, but we do our best to get the livers with blood flowing again within 8 hours of when the blood flow is stopped in the donor, because if you wait much longer, they start to spoil.
Yeah, that is just absolutely miraculous. I have the utmost respect for your work ethic and your round-the-clock responsiveness, and I know for the patients too, it's got to be a strange juxtaposition of potentially waiting a very, very long time, but then all of a sudden having to go very, very quickly. So how you balance that's amazing. And thank you also for sort of explaining all the different data points. One of the reasons, in fact, we wanted to do this tumor board is to explicate all of the different data analysis that has to happen in each patient. And I hope we're being pretty clear that doesn't happen at one static point at the beginning. It actually is iterative, and it happens appropriately at different times. Dr. Roberts, we talked about shifting sizes of tumors. Do you see shifts in liver function that either exclude patients from consideration for treatments or perhaps render them eligible? Does that happen?
Yes, that does happen. This is related in part to the natural progression of people's liver disease, the underlying liver disease, and also sometimes to the fact that if we have progression of the tumor, then that can affect the function of the remaining liver. The other factor that we have to deal with that a couple of our colleagues have mentioned is the fact that in the course of treatment with some of the different modalities we use, those treatments, since they need to encompass more than the tumor itself. So in order to effectively treat a tumor, often you have to treat a rim around that tumor, for example, when you do an ablation. Then that means that we are, in a sense, sometimes removing liver that is functioning and that is helping to maintain function for the patient. So it's important to have those considerations in mind when we decide how extensive a particular treatment will be.
Very well said. So I wanted to shift, and this is maybe betraying my own bias, but I also know we have limited time left. We talked somewhat into the realm of more advanced disease. So everything we've talked about so far is predicated, at least partly, on the possibility, at least, that the disease was contained within a reasonable field, whether that was a radiation field, an IR field, a surgical field. What I wanted to address as a medical oncologist, and these patients are near and dear to my heart, are patients whose cancer has spread outside of the liver. And that does happen. And again, this is selection bias, but in my practice, it's actually more common that I would encounter someone in that situation than someone that has their cancer still confined to the liver. So Dr. Roberts, you do a wonderful job kind of shepherding patients with liver disease along and watching them and being very vigilant. As we said at the very beginning, not everyone gets the benefit of that foresight and that forewarning. So one thing I wanted to say, and I want to get Dr. Brandt's opinion on sort of symptom management in this patient group, is I've seen a remarkable paradigm shift in the management of advanced liver cancer just in my career. So I started as an oncology fellow at Dr. Robertson's institution in 2009. And the previous year, there had been what we thought was kind of a landmark at the time publication called the SHARP study that brought this drug sorafenib into use. And I'll say a couple of things about sorafenib. So first of all, it's a pill that treats cancer. And this already sort of subverts the notion that all chemotherapy given by a medical oncologist is IV. This was in pill form. And interestingly, and this kind of gets a little bit back to some comments that Dr. Garcia Reyes was making, one of the hallmarks of the liver and of liver cancer is its vascularity. So its intimate relationship with blood vessels, and even the cancer's own sort of dependence on blood flow. So one of the ways that sorafenib worked was to try to cut off, if you will, blood vessels or new blood vessels that were feeding or growing around the cancer. But this came at significant cost, not just financial, but side effects. And again, the notion that a pill is somehow easier than IV is by no means something that you can assume. And the other thing I'll say that was very sobering is, while this was a landmark study, the SHARP trial in 2008, it was adding only months to patients' lives, so that patients with advanced HCC at that time were typically not living longer than a year, even with this treatment. And then, because this has been such a difficult disease to treat, I would argue that, gosh, maybe a decade or so went by, at least in my domain, without a whole lot of substantive progress. And then now, just in the last year or so, we have a remarkable number of new ways of attacking the illness, even if it is widespread or at least not a candidate for the other treatments we've talked about today. And Dr. Roberts mentioned at the very, very beginning that some of the causes of liver disease that then lead to liver cancer are viral. And the reason I bring that up is that it may be the case that the viral origin of some of these cancers leads to more mutations. We talked about our ability to sequence the tumor and see how many mutations there are. And those mutations in turn make the tumor vulnerable to immunotherapy. So in my mind, the biggest change that I've seen in the management of these patients in my practice is I can now offer them immunotherapy. Now, immunotherapy is a umbrella term, just like Dr. Chabra was explaining, radiation is an umbrella term. Perhaps the best example I can cite is not even from the HCC space, it's actually from melanoma. So President Jimmy Carter is alive in his mid-90s with melanoma that previously went to his liver and to his brain. And his treatment has been just as multidisciplinary as anything we've discussed today, and it's required a lot of different disciplines. But one of the real pillars, I think, of his successful treatment has been immunotherapy. So this was a Nobel Prize-winning achievement, the discovery that you can take T cells, the same cells that circulate in our body and look for viruses, and in some cases, you can program them to look for the cancer as the enemy. And the reason this is such, I think, a monumental achievement is, the problem with a cancer as opposed to infection is that cancer looks like self to some extent, whereas the infection is more clearly foreign. And so this notion that we can then train our immune system to realize that, no, this tumor is not supposed to be there and should be attacked with the same vigor that the T cells might go after, say, an infection, that's a huge leap forward. And indeed, it has proven effective in some, not all, but some liver cancers. And so I think opening up that avenue of therapy for these patients in a manner that is not just more effective than, say, sorafenib, but much more tolerable, generally speaking, has been an absolute game changer. Now, we still have to be careful. So immunotherapy, for instance, in its worst incarnations can actually induce autoimmunity. So now you've turned on the T cells and they're going around the body looking for targets, but they can find native tissues to attack. And that can manifest in a number of horrible ways, including attacking the gut, a condition called colitis, attacking the lungs, pneumonitis. In fact, Dr. Roberts, the very first immune therapy patient I ever treated was at Mayo. And I was terrified that he was going to lose function in his pituitary gland, because at the time that was the most fearsome outcome of immune therapy. I think I must have called him about every day his first month of treatment and asked him if he was doing okay endocrine-wise. But we've gotten better. The treatments have gotten better. We do have to be careful also the drugs that we pair with immune therapy. There's a drug called bevacizumab, which is, again, wonderful at trying to cut off the blood supply, but can actually be quite risky. It's a really interesting double-edged sword. It can induce both bleeding and clotting. And in patients who, as Dr. Roberts already informed us, might be at risk for bleeding, as Dr. Schwartz did too, with that elevated portal blood pressure, be very, very, very careful indeed with that particular drug. But my message is one, frankly, of hope, of measured optimism. Things are far from wonderful for these patients, and we have miles to go before we sleep. But given the sort of lean years where it was really only sorafenib in my toolkit, I think things look a lot better. I have to ask, somewhat wryly, for how long medical oncologists have been involved in your tumor boards, because it was actually not uncommon across the country that everyone was so familiar with sorafenib as our only option that there was really this notion of therapeutic nihilism, and it was actually, in some cases, not necessary to have the oncologist present because you guys already knew what we were going to say. So are medical oncologists involved in your tumor boards? I just have to ask.
It's a recent development at Mount Sinai, no question. We actually ran the SHARP study. Josep Lovet, who's the lead author, was here for 2 years on sabbatical at that point, and we ran it from Mount Sinai. And we, as the surgeons, actually at Mount Sinai, the people from Bayer told us were the leading prescribers of sorafenib in the U.S. As surgeons. It was just a pill, you just give it out. And so yeah, it wasn't until things started heating up with these new drugs that medical oncologists are suddenly jumping on the HCC bandwagon.
Well, we were one-trick ponies for a long time, Dr. Schwartz, and it's no wonder that you figured out, you know.
And it wasn't much of a trick.
It wasn't much of a trick, no. And again, all credit. I mean, the SHARP study was what we had at the time, and I'm grateful to your colleagues for doing it. It was seminal work, but again, to have more options now is a truly wonderful thing.
And now it's going actually back the other way. We're very interested. We just completed a first study that is out for, it's actually accepted at Lancet Oncology, using immunotherapy at the earlier stages of disease. You know, we do these things, whether transplant and immunotherapy is a bit of an issue, but when we do surgery to remove cancer, it's, you know, half the time it's going to come back.
Yeah.
And actually, the immune system seems to get worn down as a tumor progresses, and people with earlier stage cancer actually may be able to respond better to immunotherapy than people with more advanced disease. Plus, if we take a biopsy, treat the tumor, and then remove the tumor and compare the biopsy to the tumor that we remove, we may have our best way of starting to understand why it is that 20% of people get a great response, some even with advanced disease are cured, and others get no response at all.
Right.
So that this is our big interest as surgeons now, taking it back to the earlier stages.
That was wonderful. It's so beautifully circular and so intertwined. Dr. Roberts, I have to ask you as a hepatologist, you know, in the immunotherapy era, and we talked about the viral hepatitides that can underlie this very problem. Do you have to be concerned about how those viral illnesses might flare or be reactivated on those treatments?
That's a great question. So that was one of our major initial concerns, of course, with these immunotherapies, was what might the effects be on the inflammation, for example, that was characteristic of viral hepatitis. I'd have to say we haven't seen that be as much of an issue, that it's affected response to treatment. On the other hand, the growth of immunotherapy has occurred at the same time that we've had a substantial improvement in treatment for viral hepatitis. And, you know, we can now cure almost all patients with viral hepatitis C. We can suppress viral hepatitis B incredibly well. And so I think those two things, in conjunction with the efficacy of immunotherapy, have really been good news for liver cancer patients.
Yeah, that's absolutely incredible. I mean, again, to live in an era where, you know, like you said, there's this incredible ability to eradicate essentially the viral load of hepatitis C is just unbelievable. And then, Dr. Schreiber, you know, I'm invoking immunotherapy here, but I wouldn't be doing service to a radiation oncologist if I didn't mention abscopal effect. I realize it might be slightly out of bounds in HCC or not that common. Do you want to explain very briefly to the audience what that means, and then we'll talk to Dr. Brandt?
No, I thank you for bringing that up. You and I are in sync. I was thinking the same thing. In essence, you know, one of the things that historically we have known about radiation treatments is that it can both be, suppressive as well as immune activating. And there is, certainly still a lot of unknown in how do we tap exactly what we want in that double-edged sword, essentially. But one of the growing areas actually in the realm of HCC and metastatic HCC, which is really very much in its infancy, but really is looking at the utilization of radiation treatments to try to increase the antigens that the immunotherapeutics are seeing. So we know that obviously these immunotherapies are very effective when they have the right antigen that they're seeing. And so the question is, sometimes you get exhaustion of modalities, including immunotherapy. How do you sort of recharge that drug again by representing the right antigens on the tumor? If you get into a situation where it's responded for a period of time, but then it stops responding, can you sort of recharge the effectiveness of that drug? And I think those are really a very quickly developing area, not only in HCC, but obviously in other solid tumors as well. And I suspect that from a radiation oncology standpoint, that's really where we're going to try to, again, have a multidisciplinary sort of approach with our medical oncologists, certainly with all of our other team members, but in trying to see if the role of radiation is one of helping the immunotherapeutics continue to work as well as they do. The other sort of plug I will make also is, in part, in patients with metastatic disease, the other concept is one of oligometastatic. It's not so much relevant in HCC, but I think it helps to define something that's very important, is that metastatic disease is also a spectrum, I would say. So I think historically people have thought of metastatic disease as diffuse metastasis, stage 4 disease. That's sort of, I think, in the vernacular of the public, what people think of. But we have to realize that there is a degree of individuals who have a lot of burden of disease and those who have less burden of disease. And one thing that's important in HCC, as we've sort of already alluded to multiple times, is that liver function is critical. That as Dr. Roberts mentioned, tumor progression ends up becoming a big problem if it causes liver failure and then the ultimate sort of fatal complication of that. And so in individuals who, let's say, despite having disease that's not only in the liver, but maybe outside of it, but who are doing very well on systemic agents like bevacizumab and immunotherapeutics, as you've alluded to, if we find that they've done so well to the point that the majority of their disease now is liver related, and that's where their highest risk of having complications or detriment of quality of life or fatal complications is, that's where we sort of spin the pendulum back to not only radiation oncology, but to local regional therapies again. And talking through, do we then sort of do something combinatorial there where we add radiation or radioembolization or TASE? And so I think that's the other really exciting future development of the fact that in the metastatic realm, now we do have some drugs that obviously are doing better. Do we then start to shift the pendulum where we then look at local regional therapies again? So I think it's a really very exciting evolution, even in the setting of metastatic disease, which, thankfully nowadays, and I hope for the continued future, many patients do have what we call sort of durable control. Maybe not necessarily cure, but I think durable control really makes this still a chronic disease process.
As so well said, I think another change of thinking I've seen in oncology during my career is, as you just pointed out, not thinking of metastatic disease as wholly binary, as all or nothing, as being more thoughtful in quantifying just how much metastatic disease is there. Sometimes we refer colloquially to spots. How many spots are there in a scan? But generally what it means is, what is our gestalt of, in this case, the cancer outside the liver, and how manageable is it with other means? And I think, again, we've illustrated again and again in our discussion today that this is clearly a process that requires input from all of these different specialties and angles. So I want to make sure that I do service to my colleague, Dr. Brandt, and Jamie. Dr. Roberts, our hepatology expert, was kind of pointing out to us all the important things that the liver does. And so one of the reasons I wanted your expertise on this discussion was, you help me manage patients across the entire spectrum, not just of liver cancer, but all kinds of GI malignancies. Can we just talk very briefly about, what are challenges that you see as a supportive oncologist that patients with these liver problems seem to encounter in particular? Do you have any comment on that?
Yeah, I first have to apologize for being late.
No problem.
Did not go well.
Patients come first. Patients come first.
I know. So, obviously it's going to depend on what the quality of life issue is. I tend to want focused therapies first. So if radiation is going to be the best way to target the problem, instead of, we always say, the Band-Aids versus the direct tumor treatments. So I think that's the first part. If it's pain, then we, bone mets, and even I know that it sounded like, I don't want to sound or be ignorant about this, but the single fraction of treatment for patients that are not transplant eligible, TASE eligible, that those can be options to directly treat the issue. For ascites, we're going to, again, try to, the trade-off is, of course, encephalopathy for improvement in the ascites. And I think that's an important thing to think about before we jump to that procedure. And a lot of that is what do you value most to the patient? If we create more confusion in the need for 4 bowel movements a day versus draining the ascites intermittently, I think it's important to have those conversations on the front end so that we are putting the patient's goals and values as our guiding light, especially in these the patients that are dying of liver failure. That's really the important time to be having those conversations. So Dr. Lewis and I often tag team in terms of, not just the symptoms, but also the stuff that's time consuming in clinic for these quite sick patients. So I would say that, again, it's like making your decisions based on what the patient, what the patient's goals are.
And Dr. Garcia Reyes, Dr. Brandt, I think was alluding there to the TIPS procedure and potentially a trade-off in the symptom burden of the patient. So trying to balance fluid accumulation in the abdomen versus their lucidity. Do you mind commenting on that?
Of course. So the TIPS procedure, so it stands for transcatheter intrahepatic portosystemic shunt. So basically, Dr. Schwartz earlier on was talking about when the liver becomes very fibrotic and becomes hard, the portal pressure increases. It's called portal hypertension. And the way I talk to my patients, I explain to my patients, it's called kind of like plumbing. So if things start backing up, they start creating these, like varices, so abnormal vessels. Those are the ones that we're talking that bleed. And then also they can have accumulation of fluid in their abdomen, which can be, as Dr. Brandt was talking about, very uncomfortable. And I mean, I see patients sometimes that get over 10, 15 liters drained, not uncommonly every other week or sometimes weekly. So what we can offer is actually create a little bypass of the liver by connecting that portal circulation to the systemic circulation. And by bypassing, again, it's like getting an occlusion now, so like getting your plumbing, and then it can bypass the liver, and then the portal pressure drops and the fluid becomes less. As Dr. Roberts was talking about, the liver is actually kind of a filter. So then those toxins he was talking about then don't get filtered. So that can cause hepatic encephalopathy. Patients get confused. They feel tired. It can get so bad they can go into a coma. So for that, which is what Brandt is alluding to, we can give some medications. One of which actually bind those toxins, and then you can excrete them when you go to the bathroom. And one of them is lactulose. So you titrate lactulose to bowel movements. And honestly, it's a drug a lot of patients really don't like, just because you're going to the bathroom the whole time. So again, when we're talking, and then there's a lot of other nuances to the procedure in terms of, is the liver healthy enough? We go back to the MELTS or things like that. But I agree with Dr. Brandt. It's it works. It's great for some patients. But again, it's very important to have that risk-benefit analysis and quality of life priority conversation with patients.
Well, thank you so much for that mechanistic explanation. And Dr. Brandt, again, I find often when you and I are sharing these patients that we are talking about a decision about what matters the most. Is it you want to bring down the discomfort from the swollen belly, but does that come at the expense of their mental clarity? And as you and I have discussed often, I actually think it's really important that caregivers for these patients be aware that that's a potential trade-off. I think it's often very distressing for caregivers and loved ones as they see the patient become less communicative. So I think a lot of that is anticipatory, and I know that you helped me a lot in having those conversations with families.
Thank you.
Yeah. So listen, I know we've run the full gamut today over the course of nearly 2 hours talking about patients who are managed proactively with efforts at screening. Dr. Roberts mentioned. And then we moved through the assessment of surgical candidacy with the help of Dr. Schwartz. We also talked, of course, there about the role potentially of transplant. We talked about bridge therapies and therapies that can be offered by interventional radiologists like Dr. Garcia Reyes and radiation oncologists like Dr. Chabra. And then, and again, hopefully not depressingly, but importantly, we talked about advanced disease, some new hope there. but also some very serious conversations that need to be had, and these trade-offs that we make in quality of life with Dr. Brandt. So I feel like that was the full spectrum. Again, when I think about our charts today and what we wanted our audience to get out of it, I hope that you feel like we hit these objectives. We wanted you to have a better understanding of the complex process of finding an outstanding treatment plan that's individualized to your diagnosis. And I hope you've seen just the complex calculus that goes into that. We want you to be empowered to seek a multidisciplinary approach to tackle liver cancer. In fact, I would argue as a patient, you're completely within your rights to ask if your case is being studied at Tumor Board. As has been sort of inferred, it does take a certain critical mass of both patient volume and specialist expertise for a tumor board to convene. So not every clinic will have a tumor board, but especially in the era of COVID, where we've shifted a lot of our discussions to these kind of virtual platforms, there are tumor boards available throughout the country, and your oncologist may be able to tap into that expertise. And most of all, we just want you to feel comfortable and confident in your medical plan. Now, upon the completion of this, you're going to be asked to fill out a post-program evaluation. Just going to gauge, what information you thought was valuable, was this satisfactory, and did you find it worthwhile? And that's going to be aggregated, analyzed, and shared in the final October is for Livers 2021 report. But I'll just say from my perspective, having moderated this was a wonderful discussion. It proved to me over and over again why this care is so inherently multidisciplinary. It really takes a village to take care of the wonderful patients that are affected by liver cancer. And I think that really is the whole mission of the Global Liver Institute. So with that, I'm going to go ahead and close our session. Thank you so much for watching, and thank you so much to all the participants who joined us today. Thank you. Hello, and welcome to the post session after our virtual tumor board. I'm Mark Lewis. Welcome to the question and answer session after a long but hopefully fruitful discussion. And I was sitting here listening to it again, and first of all, just being very grateful for the opportunity to work in such an inherently multidisciplinary field. I think what you heard, hopefully, is that no man is an island, and no one doctor can take care of these patients with total thoroughness. It really requires input from different specialties at different times. And then the other thing I wanted to make clear is this was a little bit different than a typical tumor board, in the sense that I literally just came from tumor board this morning here. Often a tumor board is very fast-paced, again, not so rapid as to be sloppy, but for instance, in my conferences, we usually have to get through about a dozen cases in an hour every week, and that sort of throughput is necessary for timely treatment decisions. However, simple math, it's 5 minutes per patient. So the doctor who's most familiar with a given patient will often present their case in a very synoptic fashion, and then together we will look at relevant images, sometimes pathology, sometimes lab results, and try to come up with some form of consensus. And so in the real world setting, there's a lot of data. It goes very, very quickly, but there's, again, method to that. Interestingly, in the era of COVID, a lot of these tumor conferences have actually been occurring virtually in much the same medium we're having this discussion now. And I've actually seen that be enormously fruitful. Where I work, I'm based in Salt Lake City. Our healthcare system covers up to 6 states, including Utah. And we've found it really beneficial to have referring physicians call in, even if, of course, they can't be here with us in person. There's a little bit of synchronization that has to happen with calendars, especially surgeons often have very rigid operating schedules, certain days and times they know they're going to be in the OR. So we try to make sure that we respect that. But we also need them there. We need pathologists, we need radiologists, medical oncologists, radiation oncologists, as you've heard. Really a whole host of different minds being brought to bear on a single problem. But there's been some recent discussion about whether we should rename tumor boards. In the previous chat, at least, I put a comment in linking to an editorial with the notion that actually our focus is not on the tumor. I think where that phrase came from was it was very typical then and even now to spend some time in these meetings looking under the microscope at sort of key slides, soliciting the input we needed from our pathologists, especially if there was some question about, say where a cancer came from, an unknown primary, which still happens. But what I like is this notion that actually we should be calling this, patient conference and putting the focus, squarely back on the patients. To that end, there's even some talk, and we haven't done this at my institution, but some talk about whether patients could be invited to participate or present, I should say, their own case at these conferences. And again, there are some logistical problems there. If you're one of a dozen patients being presented, we can't violate confidentiality. We can't have you sort of stick around and listen to the other near dozen cases. Also, if I'm honest, one of the advantages of the conference is its impartiality. Just this morning, I was told, Mark, you have an emotional connection to this case, and I don't think they were saying it was clouding my judgment, but one of the things it really allows us to do is create as much objectivity as possible. And again, this sounds cold, but sort of peel away some of the emotional layers and attachments that we have and try to make judgments that are as impartial as possible based on data. And so there again, it might not fit that mold if a patient was understandably quite emotional and presenting their own case. So this is kind of a moving space. It's exciting, I'll say, to see modern technology being used in this manner. And again, ultimately to the betterment of patient care, as opposed to, say, traveling some long distance and incurring some significant expense and opportunity cost, seeking a second opinion, which of course is still an option for some people. I would argue these are actually built-in second and third and fourth opinions because you're getting your doctor's colleagues to weigh in. Now, usually that's at the same institution where you're already getting care. Ergo, there may be ways things are done at that institution that are done differently elsewhere. One of the things I loved about this panel was just hearing how things look at Mount Sinai versus Mayo versus here. But that being said, I am actually very upfront and transparent with my patients when they're being presented because I want them to know they're getting this sort of added benefit. And ultimately, it's to their betterment and for them that we do this. So it looks like we're just waiting for some of our other panelists to join. It looks like there may be some technical issues. I think in the other chat, Ivy, if I'm not mistaken, I did see a question posed to Dr. Chabra. I don't know if there's any way we can pull that across. Hey, guys.
Hi, everyone.
Oh, well, it's good to see you again. Ivy, do you have that question for him by any chance? Okay, thanks. Let's wait for 1 second, especially if Dr. Schwartz is able to join us. I think it was in regard to sequencing. And again, I won't use the hot button word of downstaging, but maybe it had more to do with bridging. So we'll see what exactly they had to say.
So I just read the question out loud for those who may not be able to see it, but it says, can you provide some scenarios where a combination of interventions potentially would be applied? I guess they're trying to potentially say as opposed to one or two as an alternative to full transplant. So great question. And I'll try my best to answer it, and certainly we'll also allow an opportunity to my fellow panelists to sort of jump in as well. But one of the ways I sort of define and sort of, I guess, divide the management of HCC in my mind is, one, whether a patient is a surgical candidate or they're not a surgical candidate. And I think if they are a transplant candidate or a surgical resectability candidate, I always generally tend to recommend that as sort of the gold standard approach. And I think our community sort of would agree upon that. And, interesting enough, I was having this conversation actually last night with a patient who's kind of in the early stages of a diagnosis. In the scenario of a person who may be a transplant candidate, there really is some increasing developing evidence using radiation therapy plus other modalities, for other local modalities to try to, I guess, what we've called it, try to reduce the risk of progression. So again, to Dr. Lewis's point, I will not use downstaging, but again, basically use it as a form of preventing progression, again, in part because there are many instances where a patient is waiting a long period of time to get onto the transplant list or waiting a long period of time to get a liver, or unfortunately, in some scenarios, not going to get a liver just for a multitude of reasons. And in those scenarios, there are some increasing publications that the utilization of short course radiation treatments, which can be compressed to as little as about 1 week to somewhere between about 3 weeks, going much longer, can be very effective in terms of preventing that progression over time. And I think radiation treatments are one of the many ways, and I know Dr. Garcia Reyes can also add to some of the ways that interventional radiology also has in terms of preventing that progression as patients are waiting on the transplant list. And that's one of the exciting spaces. I think there's a lot of options that are available to patients, and as we sort of understand, more about them, there's also going to be a lot more opportunity of combining different modalities. I think in the setting of someone who is on the transplant list, generally one modality would suffice. And it again goes back to a multidisciplinary discussion about what that right modality is going to be. And it's sort of really a function of sort of where the location of the tumor is, the size of that tumor, obviously the number of that tumor, and then the underlying sort of liver health of that patient. And really their preference. Sometimes they would prefer one modality over others because some may be more invasive, some may be less invasive, some may be longer, some may be shorter. All that certainly plays into which local therapy we decide on for someone who's on a transplant candidate. So I guess I'll leave it at that, as it looked like that question was sort of directed towards a potential surgical candidate.
That's very well said. Dr. Schwartz was uncanny. You joined us right as we uttered the word downstaging. We were not okay. It just felt like we summoned you with that.
Yeah, I'm sorry I had a little issue logging in, but here I am.
No problem. So actually, I'm glad you joined us for multiple reasons. One of which is in the chat, which may not be visible to you. There was actually a patient who I think was saying that while they were waiting for their liver, that the eligibility criteria changed. And I actually have to admit my ignorance here. I was curious because that sounded like a situation of sort of being on shifting sands. How often does that happen? Like how often are the criteria modified? And I can imagine that would create some uncertainty, especially for a patient who's waiting.
Yeah, there's been no change in the criteria. I think that was a misunderstanding of what either was being said or what was intended. The criteria are the same, but the priority that people get on the basis of those criteria changed. It used to be that people going on to the list would get a MELD score assigned if they met the criteria for priority, which means a tumor within the criteria, a single tumor 5 centimeters or less, 2 or 3 tumors all between 1 and 3 centimeters without vascular invasion. You would get a score, and every 3 months the score would go up, and so that it was kind of assured that at some point in time you would reach a high enough score that you would get a liver, whereas the situation changed together with the fact that the regional sharing of liver changed to a broader sharing system based on how far you are from where the donor liver is. But it changed to where now a person who gets the priority gets a score on the waiting list that is 3 points lower than the median score at which patients within the area near the hospital have been transplanted over the past 6 months. And that score does not go up over time, unlike the previous system. It already had been established in the past that people with the priority go on the waiting list and have to wait 6 months before the priority kicks in. And so that remains the same. So somebody who meets the criteria now goes on the waiting list. After 6 months, they're assigned a MELD score that is 3 points below the median score at which patients within the geographical region of the transplant center have been transplanted over the prior 6 months. So that has made it all in all harder to get livers for patients with liver cancer than it used to be.
Got it. Okay. No, thank you so much for clarifying. That was really important nuance there, especially for anyone that might have had a misunderstanding. So thank you. Dr. Garcia, I have actually a question for you. It looks like there may be one coming up in the chat here. It says, at what point with multiple IR treatments, radiofrequency and microwave ablation, Y90 and TACE over years, does it become too risky for a patient on the transplant list to receive another treatment in this, getting very granular now, Child-Pugh B status?
Wow, great question. So, and that's part of the art, part of, like you've heard us all talk why we all do this multidisciplinarily and how we talk to each other. So, and then we talked about this earlier, Dr. Chapman touched on it. The way we're involved, patients on the transplant list, a lot of times, is to help keep you within those criteria, as they were explained. So, when we're deciding, first of all, when, Dr. Schwartz and I sit and we have discuss a patient and tumor board, or we all discuss, liver function is really important, and that's why you bring up the Child-Pugh. So the modalities we choose are dependent on your liver function, your ESOL status, which we also talked about today. So how your activities for daily living and how you're doing overall. And then we decide, so, and then once the treatment, as you know, we follow you up. It seems like this patient's been having some treatment in the past, and then we follow you up and we follow the imaging, right? Sometimes we're able to actually treat and cure these tumors, so we keep a close eye on them, and then also at all this time we're monitoring your liver function as well. So we're basically looking at a lot of things at the same time: the actual disease, how you're doing in general, and how your liver is doing. And that's why I'm not, I can't see the actual question, but mentioned ablation, also mentioned so intra-arterial therapy. But that also, depending on where the lesion is, where the tumors are, how you're doing, then we kind of try to help out with those. With the goal, again, of course, of keeping you within those criteria so that you can later get a transplant. Usually the people and there is such a reality when there's just maybe we treat it so much that there's not a lot of the liver function is worsening, and it's that balancing out that we don't want you to get too sick, right? That you can't get a liver transplant. So it's the balancing act. So an actual number, I mean, if we're talking about radiation, there are some numbers we look at specifically depending on the doses we've given you, but it's a lot of clinical judgment and just really following you closely and seeing how you're doing.
Karima, can you hear the sound? Karima's sound is kind of very off for me. I'm not hearing it.
Really?
Whereas I heard Dr. Chabra perfectly clearly and Dr. Lewis. I wondered whether maybe there's something that can be changed.
The rest of you hear me or not really?
It is a little fuzzy. I to get the gist, though, is that there wasn't necessarily one sort of dogmatic, okay, you've had enough therapy, you're done. I think your point is concerned with function and how that might change over time.
Yeah, it needs to be a decision with the team each time the patient is seen, because as they get closer to transplant, and we know that they're likely to be getting a liver before too long, then we may hold off, whereas the same tumor, if they looked like they were still 6 months away, we would treat. It has to be an ongoing discussion with the whole team.
And Dr. Schwartz, I think this question is probably best posed to you in the chat about if you have transplanted someone because they had hepatocellular carcinoma, does that change their post-transplant follow-up versus someone who's transplanted for a different reason?
Well, yeah, this is not something where I've ever seen guidelines published by a society, but each program has their guidelines. At our program, we separate patients based on the findings at the time of pathology when we remove the liver into high risk and low risk categories. And we have different surveillance protocols after surgery, after transplant for the patients with high versus low risk in terms of how often we follow them up. The risk of after a transplant is different from the risk before a transplant, because before the transplant, a patient has cirrhosis. Even if they don't have a HCC, they need surveillance every 6 months because they may develop HCC. A transplanted liver is not at risk to develop HCC. The question is whether there are unrecognized metastases. And so the the follow-up doesn't go on as long. In the low-risk cases, if it's an early-stage tumor and the pathology confirms that, then we just do a scan at 6 months and a year, and we don't have a whole lot to worry about. When we unexpectedly find more extensive tumor than we expected at pathology, then we'll follow them just like a resection case with scans every 3 months for the first year, and then start spacing them out after that.
That's very well said. And there's another question in the chat here, I think that we can all address. That's, I think, trying to get at the sense that, okay, there are these national and even international guidelines that we follow. And Dr. Schwartz, one of the things I love most of the tumor sort of filling us in on the history of the Milan criteria and other ways that our approach here has evolved. But also a sense, and I think this has been clear, that different institutions still have some latitude to do things differently and how we reconcile those. And in fact, I would argue part of the purpose for Tumor Board, and certainly part of the purpose for patients seeking second opinions, is to sort of seek out when there are institutional differences and find practices that might suit them better, again, within oncologic and medical prudence. Do you guys feel like that's fair to say?
I would say so. When it comes to transplantation, because it involves sharing of organs among centers, there tend to be more broad protocols that are kind of mandatory, whereas when it comes to other aspects of patient management, there are guidelines that are accepted to a greater or lesser extent. With liver cancer, the Barcelona Clinic guidelines are out there as a framework to guide thinking, but they don't tell you what you have to do. Unlike with the transplantation, if you don't meet the criteria for a transplant, you can't get the priority, because it's the only way to manage a system where one resource is being shared across basically the entire country, and people have to be able to trust each other.
Yep, very well said. So Dr. Garcia, I hope we can hear you okay, but I think this might be a great question for you. It says, a further area of protocols are less uniform is use of biopsy. Any opinions on the use of diagnostic biopsy? And is this likely to change as genetic pathways are better understood?
Can you hear me better now?
Oh, that's
Yes.
way better. Yeah.
Yes. Okay. Thank you for letting me know, Myron. So, one of the fascinating things about hepatocellular carcinoma is that we are very good with imaging, and it can be diagnosed based solely on imaging, if you have heard about the LIRAT criteria. So a lot of times when we're looking at an MRI or a CT scan, there are these criteria, and basically that's become our gold standard in terms of diagnosing. So a lot of the times we are actually doing interventions based on these, on the imaging, because we've studied HCC for a long time, and we know that we can tell based solely on a good quality scan. So the use of biopsy, and I'll open it up to my colleagues to talk about this more, is usually in those cases where it's not clear. This has some features of hepatocellular carcinoma, but there's something here that looks a little bit more like maybe a cholangiocarcinoma, a cancer of the bile ducts. Also, if we think it might be metastatic disease. So if it doesn't have those specific criteria and we can't grade it according to that system we have, then that's a good use of biopsy. I see the question, and I think a lot of my other colleagues can talk about this a little bit more as well, but I think there is, I see somebody mentioning like genetic, like if we can study more tumor biologics, tumor genetics, would biopsies be helpful in that case? And I'm sure, right? And we heard Dr. Schwartz talking a little bit about, they're looking at the explanted liver, right? Them looking at the tumor and seeing if it's more aggressive, or I think that's a promising area in the field. But in terms of routine biopsies for diagnosis of hepatocellular carcinoma, we again use them mostly to troubleshoot, not as our diagnostic standard, assuming we have good quality imaging available to us.
That was really well said. And you mentioned this scenario, which actually comes up not infrequently at our tumor conference, the collision sometimes of a primary liver hepatocellular cancer with a bile duct cancer or cholangiocarcinoma. And I'll state as a medical oncologist, the latter, the bile duct cancers, are the example par excellence of GI tumors that we should be sequencing. Meaning that if we can get tissue, typically from a colleague like you, and we can figure out, well, what are the gene or genes that are driving this cancer, is actually remarkable to see. We talked about sort of therapeutic leaps forward in HCC. Just in the last couple of years, bile duct cancer has gone from something where we had one or two options to now a host, largely informed by this type of testing. But it all comes back to, do we have tissue to test? And again, we really lean on you and your group to obtain that tissue for us. So that was very, very well said. Dr. Brand, I might bring you in here. There's a couple questions that are coming up that I think will be up your alley. And they're getting into both personal and familial advocacy. Mm-hmm. So one that's definitely, I think, up your street is, can you address the difference between palliative and hospice care and what that means for patients with advanced stage HCC?
Sure. So I think of palliative care as kind of an umbrella that says we're going to manage your symptoms and your sources of hurt or suffering. There are lots of different programs underneath that umbrella, one of which is hospice care. So we think of palliative care as something that's during an course of an illness or a cancer, that the cancer-directed treatments are going to be the most important focus on the front end. But as someone goes through the different types of treatments and maybe having some treatments that aren't working anymore, and symptoms typically are going up at this time, there starts to be kind of an equal focus on symptoms and the cancer-directed treatments. At some point, when either the patient cannot do any other cancer treatments because they're maybe too sick or they're not working, then the entire focus goes to symptom management. And that's where the transition typically occurs to hospice care. The logistics of it are that hospice is this is brass tacks, I guess, but is a very different way of the healthcare being delivered. So it's a very conscious transition from cancer-directed therapies and palliative care to hospice care. And that often feel kind of threatening to patients, but I always think of it as a little bit of a swinging door. You can go on to hospice, and if things get better and you want to maybe transition back to cancer-directed therapies for whatever reason, you can do that. Go ahead.
Yeah, we found at our center that palliative care has a connotation like palliative care means that you're giving up on treating the cancer, and we've really taken to not calling this palliative care anymore, but rather supportive care. So we have a section of supportive oncology. You know, you have cancer, you have a radiation oncologist, you have everybody, and you have a supportive oncologist who, meanwhile, works to try and minimize the symptoms and maximize quality of life while you're treating the cancer. It's a very different thing from the connotation that people have. I don't want palliative care because that means I'm giving up. And I think it's a really important distinction to make that you made between palliative care and hospice, but that name carries a connotation sometimes that we have to kind of, educate people about.
Definitely. And that is actually what we call it in our clinic as well. I think it's actually more appropriate of a name as well. So
yeah, I was gonna say words matter so much, and I've been struck recently. Patients have told me they remember things that I said, years ago. Sometimes they even, draw a lot into, body language and pauses and inflection. It's absolutely remarkable. It really, really shows you the weight of our words. I'll just say again, objectively, Dr. Schwartz, my last job before this one, we were at MD Anderson, and we had a palliative care clinic, and the moment we changed the name to supportive care as an institution, the volume doubled. For exactly the reasons that you state, is that people were viewing the word palliative as anathema to their goals if they wanted to remain on treatment. And it's interesting, Dr. Brand, without violating anyone's confidentiality here, I mean, you and I share right now actually a patient who's really struggling with ascites, with the fluid distension. And it's often struck me as a medical oncologist, there's actually very few things I can do. I have a couple, sort of pills and treatments that help, but there's very few things I can do often to relieve the discomfort that comes with that. And working with someone like you, in fact, working with someone like Dr. Garcia can really help to relieve the mechanical burdens that these diseases can impose on our patients. And again, it's not an entirely unique symptom burden, but it's one that can be very, very bothersome. So, giving someone the ability to control that ascites accumulation is hugely important to their quality of life, even while they remain on treatment with a medical oncologist.
Dr. Lewis, the one thing I will also echo, in addition to the concepts you all made, is there's also a scientific rationale to really the incorporation of supportive oncology and palliative care. We do know that there's consistent evidence showing that it improves actually survival if it's really early incorporated into the management of cancer-directed therapy. And so I think, as everyone has said, it's sort of they supplement one another as a patient sort of goes through their journey, and one may take precedence over another depending on sort of where they are in that journey. So.
That's so well said, Trevor. Yeah, and again, for the audience who may not, devour the literature like we do, I mean, there's just a seminal paper in the New England Journal of Medicine, gosh, I guess now a decade ago, showing that the earlier involvement of palliative/supportive care and management, specifically of lung cancer patients, actually conferred a survival benefit, which was like a seismic finding in our field. And I think since then, as you said, it doesn't have to be binary between one or the other. The other thing I'll say as a medical oncologist, and you may find this too in your practice, I, for a long time, struggled with the sense of disconnection and even abdication of responsibility when I want patients transition to hospice, but it doesn't necessarily have to be that way. And in fact, very recently, when Dr. Brandt and one of her colleagues were helping one of my patients transition to hospice, they made sure that I remained involved. And again, that didn't mean they were still coming to clinic with me or getting chemo from me, but what it meant was that the hospice medical director was involving me and informing me of what was happening with the patient, and actually helped me feel like there was less of a rift when they made that change. Because again, both on the oncology side, on the patient side, there has been, I guess, some emotional dissatisfaction for years that you cultivate this therapeutic relationship in its best incarnation. It actually does go on for years. And then all of a sudden, there's this like incredibly difficult sort of severing of that alliance, and we really are working to make that less abrupt. So a couple other sort of patient questions come in the chat and tackle this. One said, I think patients presenting their case would be harder for patients with decompensated livers with encephalopathy. So again, just to be clear, it is not the norm by any means that patients are self-presenting. And again, we want to be compassionate and listen to the patient voice. On the other hand, as I mentioned, for a host of reasons, including confidentiality, jargon, or at least the need to be very, very synoptic, and objectivity, I think that's why it is not yet normal for a patient to present their own case. So I wouldn't feel that pressure. And then maybe similarly, you mentioned tumor boards are almost built-in second opinions. Do you think patients should make an effort to get a second opinion outside of their current hospital? So two answers there. One, as Dr. Schwartz said, is especially if you're going along the transplant pathway, UNOS sort of determines at a very, very high level that list, right? So there's not a lot of change and prioritization based on where you are. On the other hand, I often tell people, if you ask for a second opinion and are denied one, that's actually probably a pretty good reason to seek it out. And it gets a little bit more nuanced, if I'm honest, in cases like, say, in medical oncology. If you have an advanced HCC and it's clear that you're not going to transplant or even surgery, then actually I think there is a lot more latitude, by which I mean flexibility, in terms of how your treatment might proceed. In that case, it might make more sense to solicit opinions from my radiation colleagues, my interventional radiology colleagues, or even other medical oncologists. As I mentioned in our talk, just in the last, again, I would say year and a half, I've seen the way that I approach HCC change very, very quickly. And that change does not happen in lockstep at every institution. So some are doing the research that then becomes the standard of care. Dr. Schwartz mentioned how work at Mount Sinai actually led to the standard of care that was established essentially in 2008 until the last year or so. So institutions like that typically have these new treatments faster, so to speak, than you might see elsewhere in the country. So that's where I think second opinions might make some sense. I see some nodding, and hopefully you guys agree.
Yeah, I was just going to say from a personal standpoint, when a patient asks me if they should get a second opinion, and sometimes they don't ask me explicitly, but I actually sometimes tell them that if I can see that they're sort of on the fence or they're not sure about the decision they want to make, I actually sometimes do recommend that they get a second opinion. I think the reason being is for multiple reasons. I think one is sometimes the resources that are available or the trials that are ongoing at certain places, or the technologies that are sort of available, and I can certainly talk about sort of obviously protons, may not be available at every single place, kind of to the point that you were making, Dr. Lewis, that certain centers may be a little bit, maybe doing things a little bit differently, which may be beneficial for certain patients, but in certain situations may not be beneficial. But it's sometimes nice for a patient to really sort of exhaust all of the options before they make sort of these really sort of life-changing decisions for themselves at these sort of forks in the road that they get to. And sometimes it's also just consolation and for the confidence that what they're doing at their home institution is also what would happen if they went to, let's say, a larger academic place. And sometimes that sort of comfort level is also really very important as they're sort of going through their journey. So I think, for that reason, I really think there's a lot of utility in getting a second opinion. I generally, personally, actually do recommend to most of my patients that if they are on the fence or if they're just not 100% sure, they should by all means do so. Ultimately, sort of we're here to sort of support our patients, whether that's sort of clinically or that's emotionally, for them to be comfortable, whatever decision they sort of want to make.
With a disease like this, I think it's ideal to be treated at a place where all of the potential modalities that might be used to treat the tumor are available. I mean, you can have a tumor board, but if there's no transplant team at the hospital, then there's not going to be anybody from the transplant team on the tumor board to represent that point of view. And not to be chauvinistic about transplant centers, and there's certainly good care being delivered in the community, but having at least an opinion from a center where all of the various modalities are available, I think is good for everybody's peace of mind to make sure that the best decisions are being made.
And the capabilities of radiation oncology and interventional radiology, I personally in my career found vary from place to place. So I think that's very fair. That actually may have kind of answered another question in the chat, which was in regard to self-advocacy. So one of my favorite phrases to use is that the self-advocating patient is quite possibly the most powerful force in healthcare. And I think this person was asking, in addition to my diagnosis is presented at tumor board, what else can I do? Well, what's happened, I think, is that this paradigm has shifted from paternalism. We walk in the room, white coat, we say, you're going to do this, to hopefully shared decision making without swinging the pendulum so far that you get to what I call a la carte medicine, where we just walk in with a menu and we say, what would you like? Because there's some happier medium there where we're not entirely putting the choice on you. Like I've had some patients tell me, hey doc, you're the one who went to school for this. You pick for me based on what you think's best. And that is very kind. And then there's certain a sort of recognition that yes, it's their body and they still have autonomy. On the other hand, we collectively have been doing this for a while and gained some experience and wisdom doing so. So I guess what I would tell this person posing this question is I honestly don't think you're being difficult at all. I hate the phrase difficult patient. I don't think you're being difficult to ask, hey, do I have other options? And as Dr. Chapman said, sometimes, as we respond to you, we actually might say, hey, listen, if you want to get a second opinion, that's absolutely your prerogative. There's a term, again, I use some trepidation, called medical tourism, which means going to different centers and soliciting different opinions. And I'll just forewarn anyone that is doing that or has done that, that you might find, maybe to an unsettling degree, that you will get different opinions in different places based on different institutional practices. And I think that really the message there is that there's not always one right dogmatic way to do things. And the expert opinion is going to flourish in areas where it is not evidentially clear that you do this first and this second. So to that person, I would feel comfortable raising questions, concerns with your doctor. That's part of, I think, a modern therapeutic alliance.
As you would say, well said.
Thank you, Myron. I appreciate that. Actually, Myron, I have a very specific question for you from the chat. I think I'll know your answer to this, but I'm just curious. So this is asking about iron overload in the liver, most likely caused by iron supplements. I'm guessing they're thinking secondary hemochromatosis here. Would it change the way you screen for cancer in a patient who I believe also has alcohol-associated liver disease, but has abstained now for 3 years, currently receiving ultrasounds every 6 months? And the reason I'm bringing this up to you specifically is we talked about the pluses and minuses of all these different modalities. We talked about how ultrasound is quite literally in the eye of the beholder. There's inter-observer variability and different technical aspects. And you mentioned actually that you might prefer, in some settings, using MRI. Is this a question you might tackle for us?
Well, iron in the liver is a factor that affects the likelihood of developing cancer. But if this is a person with cirrhosis due to alcohol, then the person needs surveillance, and ideally you should do the best surveillance. It's not like you should get clearer pictures when the risk is higher than when the risk is lower. There are two separate things you have to decide. First is whether surveillance is warranted, and from a cost effectiveness basis, that's been estimated. If the risk of developing cancer is somewhere 0.5% to 1% per year, then it's cost effective to do surveillance. How to do it is a second question. Ultrasound is in the guidelines because it's cheap and available, but it misses a proportion of tumors. I would not change based on the fact that there's iron overload. If you're going to get a tumor, whether it's with one or the other, the chance of missing it is increased with ultrasound, but the availability and cost is lower. And these are decisions that are political. They go beyond what I mean. I think if from our standpoint as doctors, if money was no cost, we wouldn't be using ultrasound. We would get our best pictures and find every small tumor.
Yeah, well said. I'll just say what's probably stating the obvious is that the M and MRI is a magnet, so it makes all the molecules spin one way or the other, and so I think for someone that already has a substrate of iron deposition, I think maybe what they're getting at is, does that give you any extra discernment? And to your point, this came up again in our first discussion. MRI just gives you different detail than you get from an ultrasound. And I know for a patient that might introduce uncertainty, am I getting the right test? But you're right. I think at a screening level, at a population health level, ultrasound is much more readily available and cost effective.
Yeah, MR is a very good way of quantifying how much liver is deposited in the liver. And they report if they see a lot of iron in the liver, but it doesn't affect how clear the pictures are in determining whether there's cancer or not, as far as I know. Kareem, have you ever? I don't think there's any problem doing MR with iron.
No, and actually, as things have evolved and our imaging so much better, we actually have sequences where we can subtract the iron, and we can actually see the liver very well as well. So, yeah, no.
Well, you definitely have job security from this medical oncologist. Every time I try to read my MRIs, you guys have added a sequence, so I'm constantly impressed. So a couple questions here as we close. One I'll tackle as a med-onc. So it said it was mentioned that medical oncology was not always included in tumor boards. What has changed in liver cancer care so they're now part of the discussion? Well, again, I used the phrase one-trick pony in our earlier talk, and sorafenib was the drug that we had from 2008 until, again, roughly sort of late 2019, early 2020. So if the medical oncologist was always going to be recommending the same drug, and the other colleagues at the tumor conference were well aware that that's what they were going to do, to Dr. Schwartz's point, they were prescribing sorafenib at an extremely high rate outside even the medical oncology domain. I won't say there was necessarily an ethos of therapeutic nihilism. I would just say it was very predictable what the medical oncologist was going to say or do. So as we've discussed, we still have a long way to go, but these new options, particularly in regard to immunotherapy, have gotten a lot more nuanced. And again, to peek behind the curtain, we've talked about all these different governing bodies, and UNOS governs, what organs go where. In oncology, specifically medical oncology, there's a national group called NCCN, the National Comprehensive Cancer Network, and their guidelines largely govern what treatments we can get, meaning if I prescribe it, is it going to be paid for? Is it going to get reimbursed? And they have gotten a lot more complicated in a good way in the last year and a half, vis-a-vis these new drugs. But there again, you still have to stratify. You still have to go back to that child Pugh status we talked about earlier. You have to assess bleeding risk and the portal hypertension that we talked about. So it is now a lot less straightforward, I think, to pick the drugs. Ergo, medical oncologists are getting more involved or re-involved in these tumor conferences. That'd be my answer to that. Says, this has been a fantastic discussion. Each of your patients are very lucky to have you on the treatment team. Thank you. For those people who do not have access to multidisciplinary care tumor boards, how can we make sure all patients with liver cancer benefit from tumor boards and multidisciplinary care? Gosh, well, I guess today was hopefully part of the exercise was just to, again, make very visible and explicit what happens here. You know, I'm pretty active on social media. What I will say is it's extremely difficult to comment intelligently on someone's case unless you actually are being seen at an institution. So there are limits to what we're able to do in the virtual setting. And I think you've seen just how individualized we try to make someone's care. And that's even beyond, of course, the fact that we consider your privacy sacrosanct and all your data has to live in a firewall of electronic medical records. So that's a great question. I get the sense that, you know, Ivy and GLI, their whole kind of mission, among others, is to empower patients. But I think ultimately you're still being led one way or another to a site of clinical excellence. I don't think there's a way to necessarily bootstrap this on your own. I don't know how others feel. Dr. Chabra, I see you nodding.
I was going to echo that. It kind of goes back to a little bit about sort of second opinions, but maybe it's a 1.5 opinion. You know, if you are at a place that, you know, as a patient, you are diagnosed with liver cancer, that you're not necessarily sure that the location or the hospital or the clinic that you're at just has that expertise. And that's totally okay. Not every place has to have every expertise. But if you feel you're sort of at that place, I think it's really worthwhile for you to connect with resources like GLI and other liver tumor, try to have them potentially help you navigate where you could get some more information. But similarly enough, it may not be a bad idea to contact a center that is a liver tumor center of excellence. And I think one of the silver linings of the pandemic has been the ability to do telehealth, teleconsults, right? And I think that's, you know, probably a lot of the individuals on this call are doing that. And I think that does help patients now in terms of not having to travel, but be able to sort of get information that may not have been available to them, you know, a few years ago. And I think from that standpoint, what I would say in short is really GLI and advocacy groups as such, but then also similarly really doing your homework. And if you do find places that you feel are more liver tumor centers of excellence, potentially reaching out to surgeons or medical oncologists or radiation oncologists, really anyone you think you could sort of tap into, and then you could potentially get some more additional information through that pathway.
That's really well said. I think, you know, pandemic's been horrific, it still is, but there's been a silver lining in realizing what we can do. It's still appropriate in terms of virtual care. I've realized, you know, I miss physical exam. I miss the tangible and intangible aspects of being in a room with a patient. But I think a lot of it, to your point, especially if you're doing like a second opinion or you can do a high-level overview of the case, I think that can be accomplished through telehealth consultation. Dr. Schwartz, one last question for you, and then we'll wrap up. And this is pretty specific. It says, is there any possibility of surgery on a 14-centimeter tumor that has not spread outside of the liver?
Yes, the size of a tumor is important in transplantation because there are criteria that are based on size, which is related to the likelihood of a tumor having spread. But when it comes to surgery to remove the part of the liver, a resection, there's no size limit. And in fact, a tumor that reaches 14 centimeters and still appears to be well confined and without spread outside the liver actually tells you that that tumor isn't one that has a strong tendency to spread. And so that we remove tumors that big and occasionally twice that big, you know, when they come along, and people can do perfectly well.
That's great. Thank you so much. That's impressive what you guys can do in the OR. So I believe what we're going to do, guys, is wrap up and then have Ivy join us. And again, we're very grateful to GLI. They are quite literally our hosts here. They put a lot of time and planning into this panel. We quite deliberately. We're trying to solicit different voices in terms of the clinicians that tackle HCC and try to help our patients, but UCLI has definitely been leading the way. And Dr. Chapman mentioned really is a fantastic resource for patients and advocates as they try to deal with this together. So Ivy, this is your show. We'll turn it over to you to close.
Thank you so much. I just wanted to take this opportunity again and thank each of you for joining us, for helping us and guide us as we, really sort of set the direction for, elevating the global dialogue about liver cancers. Dr. Lewis Roberts isn't here, but he sent his greetings. He had procedure. So with that, I just, like I said, want to thank every single one of you, the time that it took to prep for this, to pull this together, and then just to be available for the questions is just incredibly meaningful. And special thanks also to our audience who came and was able to enjoy the program and ask some really thoughtful questions. And, we look forward to doing this every year as part of our October's is for Livers campaign. So thank you very much and have a great afternoon, everyone.
Wonderful. Thank you so much.
Thank you.